30 to 40% of women may experience a recurrence within 5 years. However, the interesting thing about triple negative breast cancer is that even though the risk of um, the risk of recurrence or the risk of the cancer coming back increases within the first 5 years. Usually, the peak is about 3 years, and then it starts dropping. Even though that is the case, after 5 years, the risk of recurrence drops very significantly as compared to other subtypes like the hormone receptor positive one, where the risk of recurrence can go on for decades. So, for triple negative breast cancer, if you are able to reduce the risk or prevent the cancer recurring within the first 5 years, then you have a better chance of preventing it from recurring down the line. Okay, you have a better chance of actually curing the patient. Okay, so because of that, it's very important for us to have treatments that can reduce this risk within the first 5 years, because you know that when you cross the first 5 years, then relatively you are good to go. Next slide, please. Okay. Okay, so coming immune checkpoint inhibitors or ICIs. Okay, so what are ICIs? Immune checkpoint inhibitors. So these are basically drugs that inhibit immune checkpoints. So what are immune checkpoints? Okay, so usually, um, when the body is exposed to something foreign, like an infection or even a tumor cell, cancer, the body brings in white blood cells or immune cells to the site of that foreign body, to the site of that cancer, to try and eliminate the threat. Okay. So the immune response is what the white cell uses to fight against that threat. Okay. So the immune response goes on for a while, but it can't go on forever, because that might give the person problems. You can't have an immune response, inflammatory response, an unending one, because that might lead to problems in other tissues or organs. So the body itself put it has put in place a mechanism to dampen the immune response after it has gone on for a while, and that is known as the immune checkpoint. I'm sorry, I don't have a pointer, but if you can see in the blue cell, okay, that's one of the immune cells. There's something there called PD-1, okay, and it is attaching itself to something called PDL-1. So that is an example of an immune checkpoint. So the immune cell or the white blood cell, which is in blue, has a receptor, which is like a keyhole. When it finds its key, that is on another cell. The key is the PDL-1. When they find each other, then the immune checkpoint is activated, and that causes the immune response to calm down. Okay. So there are other immune checkpoints like the CTLA4 and others. Okay. So if you can remember, the immune cell is trying to destroy the tumor cell. The problem with tumor cells is that sometimes they are able to develop the key to the PD-1, so that when they interact with it, then the immune response is dampened, and then they are not able to. So the tumor cells are able to develop this PDL-1 receptor, interact with the PD-1, and activate the immune checkpoint. So when that happens, the tumor cell or the immune cell is unable to control the tumor cell any longer. It's not, that is a phenomenon known as immune evasion. So it's like the tumor is able to escape the regulation of, or is able to escape its control, just because it has activated this immune checkpoint. Okay. So it goes to stand that if you are able to find something that blocks this immune checkpoint, then the immune response will be activated. It will continue to go on, and then the white cell or the immune cell will be able to recognize the tumor cells, and then it can go on to kill it. All right. Different drugs have been developed to target di- various sites along this pathway. So we have drugs that target the PDL1 on the tumor cell. We have drugs that target the PD1 and then even CTLA4, just so that the immune response can go on and then take care of the tumor cells. So why is this important in a cancer like triple negative breast cancer? So it's been found that in triple negative breast cancers, the triple negative breast cancers are able to better attract immune cells to themselves. So when you look at the what we call the tumor microenvironment, when you look at the cells that surround the triple negative breast cancer, a lot of them are immune cells. Okay. For the clinicians here, triple negative breast cancer has what we call a higher mutational burden than other subtypes of breast cancer. So what that means is that it's able to produce for more foreign antibodies that are recognized or are recognizable by the immune cells for targeting. So if you are able to switch off the immune checkpoints in a triple negative breast cancer, then you are giving the immune cells around the cancer the chance to recognize the disease and then target it. Okay. All right. Next slide. So now we'll look at immunotherapy in early stage breast cancer. We'll go on to look at it in metastatic disease. Like next slide, please. All right. So there was a study by um, Lin and others. What they sought to do was look at the different combinations of drugs that we have to give for triple negative breast cancer in the neoadjuvant setting. When we talk about neoadjuvant, we just say it just means that the drugs we give before surgery. And there's something called a pathological complete response. So that simply means that when the patient has had chemotherapy or systemic therapy and the patient has had surgery, when they look under the microscope, when they take the specimen, either the tumor specimen or the mastectomy specimen, look under the microscope. They just want to see whether the chemotherapy has been able to remove all of the breast cancer, all of the cancer from the breast. That's a complete response to the tumor under the microscope. Now it's been found that for, for tumors that are able to have a pathological complete response, the patients go on to do much better than those who don't have the complete pathological response. So it's an important thing. So this trial looked at the various combinations of chemotherapy that are available or systemic therapy that are available to patients before they have surgery. And what they found that was that right at the top, you have the combination of the PD1 inhibitor that we talked about, plus a chemotherapy agent called platinum with anthracyclines and then taxane based chemotherapy. So these are all chemotherapy drugs. Usually we would give anthracycline and then anthracycline based chemotherapy and then go on to a taxane. But this study showed that for adding the PD1 inhibitor plus a chemotherapy called the platinum to these other ones actually improve the pathological response to a greater degree than the other combinations. Okay, next slide. All right. So there was there's a landmark trial that looked at the use of the PD-1 inhibitor, pembrolizumab, and in fact, the previous slide. This is part of the data that informed that. So the Keynote 522 study, they looked at patients with newly diagnosed triple negative breast cancer. That was either stage 2 or stage 3. So stage 2 to 3. So um so tumors that were greater than 2 cm and then may also have lymph nodes. So the study was in so they randomized patients to either neoadjuvant chemotherapy with carboplatin, that's the platinum agent we spoke about, and then that was followed by the anthracyclines with cyclophosphamide with the PD-1 inhibitor versus the same treatment without the PD-1 inhibitor. Then the patients went on to have surgery, and then after surgery, if those who needed radiotherapy went on to have radiotherapy, and then they continued with either the PD-1 inhibitor for up to a year of treatment, or they gave them a placebo. That's just um, inactive drug. Okay. Next, next slide, please. Okay. So what they found was that the patients who had been on Pembro, that's the PD-1 inhibitor, they had a higher rate of the desired pathological complete response compared to the patients who did not receive it at all. So that was 64.8% compared with 51.2% in the patients who had not received the drug. Next slide, please. They also looked at something called event-free survival. So event-free survival just simply means how many patients during the time that we followed up did not have any events like a recurrence of the disease or a progression of the disease or death or develop a second cancer. And they found that those who had the PD-1 inhibitor, that's the green line, did better than those who did not have it. So that's both at 3 years and then at 5 years here. Okay, so at 5 years, those who had it still did better than those who did not have it. Next slide. So they also tried to break it down into the patients who had the pathological complete response and those who had not. So for those who had not had a pathological complete response, they still found that at 3 years, those who had the PD-1 inhibitor did better than those who did not have it. Those who had pathological complete response at 3 years, it looked like it was the same. However, at 5 years, we say the curves begin to separate. So it means that there's a difference. It's not significant yet, but follow-up is still ongoing. But for those who did not have the pathological complete response, there was still a significant difference even at 5 years. Okay, next slide, please. Right. So a similar thing for what we call disease progression-free survival or disease recurrence-free survival at 3 and 5 years. How many patients didn't recur? How many patients did not progress at 3 and 5 years whilst on either treatment arm? And there was also a similar finding. Those who had had the PD-1 inhibitor did better than those who had not at 3 years and then at 5 years. Okay. Next slide, please. So this is just a table showing something we call the subgroup analysis. So what it does is that it just breaks down the whole cohort of patients into the different categories that they fall under. So those who, in terms of nodal status, those who had positive lymph nodes or negative, tumor size, the chemotherapy schedule, the PDL1 status. That's whether the patients had PDL1 in the tumor. That's something that could, um, or let me put it this way: the PDL1, when it's measured, it gives an idea of whether the patient is going to respond or not to the immunotherapy or the immune checkpoint inhibitor. And they found that whether the patient had um, was PDL1 positive or negative, the, they still did better with the drug. So as you can see here, this side, when the those at this side of the line, it means that they did better with the drug. And then when at this side, it means that there there really wasn't any benefit, or it favored the placebo. So you can see that for most of the patient categories, they fell on the left side of the line, showing that there was a benefit for adding the PD1 inhibitor to their treatment. Next slide. So, in terms of adverse events, so something that we tend to be concerned about when using um, immune checkpoint inhibitors or immunotherapy is what we call immune related adverse events. So, because you have turned on the immune switch, it means that immune responses are going on and they can affect other organs of the body. So, that is something that we have to pay attention to when you are using immunotherapy or immune checkpoint inhibitors. So, um, some patients can go on and develop inflammation in other organs in their body. So they measured um, they put together the number of patients who had the immune related adverse events and who had to discontinue treatment, and the ones who had to interrupt treatment because of these immune related adverse events. And they found that um, for those who had had the immune checkpoints inhibitors, just about 7.8% had to stop the treatment altogether, and then about 5.5 had an interruption and then went back to the treatment. So it wasn't very high. Next slide. Okay, so because of the data for yes, please. Because of the data from this trial, we found that the NCCN guideline, that's an international guideline that we use, shows that for high risk triple negative breast cancer, that's stage 2 and stage 3, you should actually offer the patient the PD1 inhibitor, pembrolizumab, plus the other chemotherapy agents that we spoke about. Okay, next slide, please. Okay, so I think I'll skip this slide. This is just the algorithm of what to do when you have a patient with early triple negative breast cancer, and it takes you through all the pathways down through what we've spoken about. That for patients who are stage 2 and stage 3 in the neoadjuvant setting, you actually should offer them PD1 inhibitors plus chemotherapy. Next slide, please. Next slide, please. So we'll move on to metastatic triple negative breast cancer. Okay. And similar to the new adjuvant setting, the use of PD one inhibitors has also been approved in this setting. Okay. We can skip this slide. So the trial that actually brought this to bear was another keynote study, Keynote 355. And they looked at patients who had metastatic triple negative breast cancer, who had maybe they had been treated in the past and had developed metastatic disease. And they were randomized to pembrolizumab with chemotherapy or a placebo with chemotherapy alone. And they took the drugs until they progressed or the study ended. Next slide, please. Okay. And they found something interesting. There's something called the CPS, or the combined positive score. So it just gives an idea of the percentage of cells in the tumor which express PDL1 relative to the number of tumor cells. So it's a scoring system for how well the patient is likely to respond to the treatment. And they found that for patients who had the PDL1 score of um, 10 or more, they did better with the use of pembrolizumab rather than those who had a lower score. Next slide, please. Please go back just one more slide. Okay, so this is a similar thing. So here they measured overall survival. That is how long the patients were able to survive on the drug. And they also found a similar thing, that those who had um, the score greater than 10 actually did better on the drug. Okay. Next slide, please. Next one. I think you are going back. Please, let's go for it. Okay. So in terms of the adverse events again, also something very similar. Just a few patients, just at the tip, had really bad adverse events. That's grade 3 and grade 4, whilst on the PD1 and chemotherapy. Okay. Next slide, please. All right. So again, for with the NCCN guidelines, as first line treatment for metastatic triple negative breast um, cancer, for those who have a PDL CPS score of greater than 10, PD1 plus chemotherapy is also is actually the first line that is recommended now. Next slide, please. Okay. So just to summarize, so like we said, triple negative breast cancer is an aggressive subtype of breast cancer and with an adverse 5-year prognosis. And the reduction in the risk of recurrence during this period is essential to achieving prolonged survival for patients. So from the trials that we've seen, we realized that PD1 inhibitors, particularly pembrolizumab, has actually been approved for both high risk triple negative breast cancer and then for metastatic disease. Okay. But what does this mean to the patient? It just means that now the patient has a greater power of choice in choosing the best regimen for her disease. Although, of course, that has to be balanced with toxicity, both both immune related events and then also financial toxicities as well. But I'll leave the drug rep to talk about that. Okay. Thank you.
Thank you. Now we have Dadzi. She's going to speak on the role of immunotherapy in cervical cancer.
I like the interesting expressions on people's faces when they had cervical cancer. I can see very interesting expressions, but I think this is a good platform, first for knowledge sharing and also for impact. so that since we are talking about women's health, so that for every woman that enters your consulting room, you have the opportunity to ask if they've had a pap smear, or if they are eligible, if they've had vaccination. And I hope that all of us have had our pap smears done. Or HPV testing. And not, I mean, all of us women here have had our pap smears done, or HPV testing. All right. Okay. So I'll try and get out of your way in a very short time. If you could give me attention for a short while, I'll be out of your space. So we're talking about immunotherapy in cervical cancer. It's something new and something interesting that we can all pick something from. So I believe that, next slide please. I believe that we've heard a lot about our cancer burden as a country from Global Can 2022. Yes, this is my disclaimer, and I have no conflict of interest to declare. Yes. So next slide, please. I believe a lot has gone about our burden, the cancer burden that we have in our country. Next slide, please. And when you put both sexes together, cervical cancer ranks third among all the cancers we see. Breast, liver, and then cervical cancer, which affects women. So it's important that we talk about it. The next slide. When we talk about women, it's the second component. Now, if you look at our center where we treat the patients, that's the National Center for Radiotherapy and Nuclear Medicine. Can we have the next slide, please? We can see that there's been an upward trend. I can't explain the drop in 2016, but I know that for 2020 it was because of the COVID. Slight drop, and then we can see that it's increasing steadily. Can we have the next slide? The interesting thing is that we have quite a large number of patients coming in advanced stages, so that more than half of our patients come in stage 3 and 4, and about 75% stage 2 and above. So stage 2 is a tumor on the cervix that has spread into the side. It then goes down all the way to the vagina, and then it can spread to the side walls. It can go into the rectum. It can go into the bladder. So women come in presenting with what we call incontinence, urine coming through the vagina, or fecal matter just coming out of the vagina. That's the stage 4. And we have quite a large amount of patients coming in these stages. Can we have the next slide? But since the year 2000, we know that the management for these advanced stages is what we call concurrent chemoradiotherapy. So you combine radiotherapy and chemotherapy. These diseases are very advanced, so you can't do surgery. So when they're advanced, we treat them with radiotherapy and chemotherapy. And since the GOG 85 and GOG 120, it's become the standard that those who have chemotherapy and radiotherapy are able to do well. They have improved disease-free survival and overall survival. Can we have the next slide? So as I said, since the year 2000, thereabouts, that is how we treat the very advanced cervical cancer patients. For the early ones, you can do surgery, but for the advanced ones. However, we know that the greatest benefit is even in very early ones. So that for those who are advanced, the benefit is not that great, even when you do all these advanced treatments. Next slide. So over the years, we've tried to advance in technology just so that we can improve survival, and just so we can give them good quality of life. Because as I mentioned, these patients will come to you and tell you that, I mean, as far wherever they are coming from, they would have to pick dropping and come, because they can't pick the public transport because of the offense, the discharge. They are stigmatized. Sometimes comments are made. And so you want to give these women a good quality of life, at least. However, we know that they do have recurrences, and that is the issue. Even for the early stage, let's say 1B. 1B is a lesion that's just about more than 2 cm. That is just on the cervix. Even after treatment, you have as many as 22% coming with recurrence or persistence. That's after treatment, the disease comes back, or the disease is still there. And for those that are advanced, such as 2B and above, as much as 64% will have recurrences. For those who are stage 3 and stage 4, you can have as many as 70% coming with recurrences. And this is, as I said, in spite of the fact that we've advanced in technology with what we call IMRT, try to boost the nodes and treat the nodes, all that, and do advanced techniques, brachytherapy. But even that, they will still come with recurrences. So what do we do when these patients come with recurrences? And I can tell you that if you talk to any of my oncologists, they will tell you that these are the patients that when you see, you'd want to pretend you need to use the bathroom so I don't see them. Because it can be a burden. This is a patient who has gone through this hectic treatment and is still having offensive vaginal discharge, probably a fistula, having fecal matter, and we always say that nothing works. That's what we used to say until now, that nothing works. So when you see them, you would want to make an excuse and let somebody else see, but then sometimes you have no choice but to face them. So can we have the next slide? So if the recurrence is very limited and is central just on the cervix, hello, okay, with no metastasis, you can do what we call pelvic exenteration, but trust me, no gynecologist wants to do that, because that means removing the whole uterus, vagina, cervix, rectum, and then leaving the woman with a bag, both colostomy and a urine bag. And so most patients will even refuse it, and most surgeons will not do it. For those that you can re-irradiate, but re-irradiation is very tricky. You need to be careful. So for those with persistent or recurrent or metastatic cervical cancer, what do we do? So the preferred regimen is chemotherapy, platinum-based chemotherapy with paclitaxel, and a targeted therapy called bevacizumab. It showed that there was some improvement in survival, and that was in a study, a GOG 240 study. Then we went on to immunotherapy, pembrolizumab. When used alone in the Keynote 158 study, showed that there was some overall response rate. And so that formed the basis for more advanced studies in immunotherapy. And so we'll talk about the next slide, please. The Keynote 826 trial. So this was a phase 3 double-blinded randomized control study where patients with persistent disease, so they've had their treatment but they still had tumor, they still had the symptoms, or recurrent disease. That means they were free of tumor of disease for some time and it's back, or metastatic diseases, were randomized to have pembrolizumab and chemotherapy versus a placebo and a chemotherapy. And let's see what happened. Next slide, please. So these patients were more than 18 years. They had a persistent disease, recurrent or metastatic disease. It was either a squamous cell carcinoma. Most of the cervical cancers are squamous cell. More than 90% is squamous cell, or adenosquamous or adenocarcinoma. And they had disease that you can measure because you want to make sure the response is good. And they had good performance status. Next slide. So we've talked about the immune checkpoints. I don't want to go. I know it will bore you, but I believe the previous speaker did a good exposition on it and you understand. So next slide. So PDL testing was done. PDL1 testing was done. And the wonderful thing is that now in Ghana, we have some labs that do PDL1 testing. We have a few labs that do those tests. And it's just an IHC, immunohistochemistry test. It's not that complicated. You just need the reagents. And as I said, thankfully, we have labs that run these tests. So once those tests were done, the patients were randomized into those who had a combined positive score of less than 1 or more than 1, or 1 to 10 and more than 10, just to show the intensity of the PDL1 positivity. Next slide. So why do we use it in cervical cancer? We know that most of the cervical cancer, almost all of them arise from HPV infection, human papilloma virus infection, and that sets as an immune cascade going. Secondly, most of the cells have expressed the PDL1. And then it's believed that when patients have radiotherapy, it sort of sensitizes the T cells, primes them, and so makes them more susceptible to immunotherapy. Let's go on, please. Next slide. So the patients were well matched, and this was how they were randomized. One group had pembrolizumab with paclitaxel and cisplatin with or without bevacizumab, and the other group had the placebo with paclitaxel, cisplatin with or without bevacizumab. Next slide. And they were well matched. So the control group and then the experimental group were equal in characteristics. Next slide, please. So for progression-free survival, progression-free means that from the time of randomization, the disease did not progress, and they did not progress. They were either stable or responded well. For those who had the pembrolizumab, you can see that they had improved progression-free survival compared to the placebo arm. Next slide. And this benefit was seen in all groups, irrespective of age, histology, irrespective of whether they had their performance status, whether they were metastatic or not. They all did well. Next slide. Again, when you randomize them according to the PD-L1 testing, whether they were less than 1, more than 1, the intensity score, there was also no difference in that whether the score was less than 1 or more than 10, they all did well with the pembrolizumab arm. Next slide. And again, whether it was or adenocarcinoma. So previously, when we see patients with adenocarcinoma of the cervix, we put our hands on our head because we know that they usually don't do well. And the sad part is that a lot of them are quite young, in their late 20s and early 30s. They usually don't do well. And so once we start, it's like we're anticipating that they wouldn't do well. But in this those that were non-squamous also did well in the pembrolizumab arm. Next slide. And depending on the kind of chemotherapy, carboplatin or cisplatin, there was still benefit in that same pembrolizumab arm. Next slide. Again, the use of bevacizumab. So for us, this is important because it adds to the cost. But then again, those who had that bevacizumab added to the immunotherapy versus those who did not have, there was also benefit for those who added versus those who did not have. Next slide, please. It also did not matter whether they had had previous chemotherapy. Next slide. That was the progression-free survival. Now, if you talk about overall survival, so to take those two arms, time of randomization to death, and death can be, it doesn't need to be because of the cervical cancer. Those who had the immune checkpoint inhibited did significantly better. Next slide. Again, this improvement was seen in all subgroups. Next. It didn't depend on the intensity score of the PD-L1. Next. It also, histology did not affect it, whether it was squamous or non-squamous. Next slide, please. And the type of chemotherapy used did also not affect the outcome once they were in the experimental arm. Next slide. And whether they used bevacizumab or not. Next slide. It also did not depend on whether they had had radiotherapy or not. Those who had had radiotherapy versus those who had had no previous radiotherapy did well on the experimental arm. Next slide. So we want to talk about what we call response, general response. So when you are doing a trial, you want to see if the patients are responding. And we use what we call RECIST, is response evaluation criteria in solid tumors. And you group it as to whether they have complete response, partial response, stable disease, or progressive disease. And we can see that for those who were in the experimental arm, they had better complete response and partial response compared to the experimental arm, whilst the placebo arm had more stable disease and progressive disease. That's what has been circled down there. Next slide, please. Also, these responses lasted longer. So you can have a good response that sometimes you get a patient, you give treatment, and the response is great and you're happy. And then within a short time, they come back, and it's very sad to see that. But these ones, the responses were prolonged for those in the experimental arm. Next slide. Now, we've talked about these immune-mediated adverse events, as my previous colleague said. The thing about immunotherapy is that you need to be well vexed in it to be able to administer it, since you can have toxicity from top to bottom, because of these checkpoints that have been inhibited. Ideally, these checkpoints should stop at a immune response at a point. But in this case, because of tumor, or because you want to control the cancer, you've inhibited the checkpoints. So the immune response can go on and on. So you need to be well vexed in managing these toxicities. Next slide. So when we look at the adverse events, for those that were immune related, they were more in the experimental arm. But generally, there wasn't, the general adverse events were similar, except for the immune mediated adverse events that were more in the immunotherapy arm. Next slide. So in conclusion, based on the Keynote 826 trial, FDA approved it for recurrent metastatic and persistent cervical cancer. And we found that after a median follow-up of about 39 months, the addition of the immunotherapy with or without bevacizumab, which makes it good for us to cut costs and continue to show substantial and clinical meaningful overall survival and progression-free survival. It didn't matter whether it wasn't based on age, histology, chemotherapy given. The benefit was seen in all subgroups. Again, the safety profile was manageable. Of course, the adverse events related to immunotherapy was more. Yes, and as we need to vex ourselves well, immunotherapy. The truth of the matter is that where oncology is going, immunotherapy is facing us, and it's here to stay. And it's time as a body that we embrace it, we learn about it, and we see how best we can use it to improve patients' quality of life and patient survival, both in breast cancer and also in cervical cancer. Thank you. At least it gives us an option for our patients. Thank you.
Thank you, Dr. Dazi. Now we have pharma symbiosis, a representative of pharma symbiosis, and we have 10 minutes.
Before I present a quick announcement, the last program for the day is the business meeting. That's where we discuss the way forward. We discuss the strategy group, and then we vote for our new leaders. So those who can vote are those who are in good standing. So if you know you are not in good standing, you can pay your dues right now and vote. So because we are going to print the ballot papers, we don't want any what do you call it? We don't want no excess. We don't want any rigging. People to say we have rigged everything. Can we have a count of those who have are registered members in good standing, so that we can know how many ballot papers to print? We're just around the way. Flo, are you? Flo is our electoral commissioner. So the front. What? Who's standing with those who have paid their dues? Or please,
Good standing means you've paid your dues up to 2024 dues. So as a reminder, the dues for 2024 is 200 CDs for members and 100 CDs for survivors. Last year dues, if you are owing, I'll still collect it. It's 100 CDs. Thank you very much.
okay, again, just 25 for those here. Easy chair. Pass me 26. Easy chair. You have your number. 27. So 27 here is Elira. So 27, 23, 50. 50. 27, 25. So around 50. Okay, Reginald, the floor is yours. Oh.
Two. Technical team, do you have the slides ready? Good afternoon. So my name is Reginald. Good to see you again. Yesterday I was standing in as the MC, but today I will doing a very brief presentation on behalf of Farmer Symbiosis because I'm the franchise manager for Farmer Symbiosis. Many of us here are very much familiar with Farmer Symbiosis, so I want to tell a very brief story about Farmer Symbiosis today. Farmer Symbiosis is a fully owned African company, and it was started in about 6 years ago by a visionary, one of our, a very prolific Ghanaian who saw a gap within the pharmaceutical industry and felt that Africans needed to provide solutions for their own people. Next slide. The image here is what you see when the name Africa is mentioned. Usually people will say it's either a dark continent or full of troubles. When it comes to the troubles, usually it's either the laws, the issues about regulatory risk and all that. So the typical Makola situation, when you go to Nigeria, you see the same thing. You move to other African countries, you see this kind of a cocktail of chaos, so to speak. So it makes a lot of people wonder whether it's worth doing business or providing solution for a continent such as ours. But Africa is full of lively people, full of healthy people who equally deserve what the developed world also has in terms of healthcare solution. So this is where Farmer Symbiosis comes in. Next slide. So as Farmer Symbiosis, our purpose is to be the preferred partner of choice for various pharma companies. So we are an umbrella company that offers all kinds of services, which I would touch on very briefly. We are driven by 4 core values. The 4 core values has to do with passion. If you are not passionate, yesterday I saw the passion with which our sister from the north, Atika and co, were driving home their stories. I saw the passion with which various survivors were also sharing their sentiments. And that is what drives us as an organization, passion. We are also driven by innovation as a company, because as the world moves every day, something new happens and you should be able to change to be able to adapt to the new system. Then also, we are driven by integrity. Every single thing, whether it's a service, whether we are dealing with any health system, we believe that the overarching principle has to be integrity, but more importantly, patient-centeredness or patient-focused. In fact, that is the reason why we are all here. The reason why we have been here yesterday and the reason why we are here today is because there's a conversation around the patient, which can either be you or I or a family member or a friend that you know. Next slide. So at Pharma Symbiosis, what do we do? People would always ask, Pharma Symbiosis, how different are you from the other pharma companies? It's a family that does 4 broad works in terms of within the healthcare space. The first one has to do with policy work. Yesterday, you realized that most of the conversations that we were having, fortunately, we had some MPs who made some commitments on how things can change if we work together as a group. So in Pharma Symbiosis, we have the local expertise, people who have worked within world-class compliant institutions to be able to help shape policy. And this is where, for instance, when it comes to conversations about cancer or oncology, we can be very instrumental as an organization. So we do a lot of policy related work. The second one has to do with access. Access is closely tied to policy. So, for instance, there are certain medications that we want governments to get on a large scale for a group of patients, in this case, oncology patients, that falls within the remit of access, and we can also do that. The next has to do with regulatory. It's not just about importing medications. We don't directly import medicines, but we have the expertise to ensure that whatever medications that are coming in, we have the right person who would put all the documentations together to make sure that whatever medicines are coming in are of world-class quality. This is not African quality, world-class, so that wherever they are to be used, there's a need. Wherever they are to be used, we do not deprive our people of the quality. I use world-class because sometimes we say, oh, we are here, so we need to abide by a certain standard. There's only one standard, and it is world-class. So whether it's from Africa, it should be we should be able to use that medicine in the US or in any other developed world. So it's not, it shouldn't be the other way around, where they use the best of medicines and we have our different standards. There's only one standard, which is what we help to ensure. And then finally, when it comes to marketing, and that's where usually you see some of our reps in various institutions. Our reps do not talk directly to patients, they talk to clinicians. And people normally misconstrue to say that medical representatives are there to sell medications. That really is not the case. What medical representatives do is to provide quality information to doctors, nurses, midwives, pharmacists, for them to be able to make informed choices when it comes to medicines or healthcare solutions for the health system. Basically, these are the 4 points or the 4 pillars within which Pharma Symbiosis operates. Next slide. So, in terms of our footprint, we are not only in Ghana, and because we operate across all these countries, we operate in Ghana, we operate in Nigeria, Kenya, so 22 African countries as of present and still counting. So yes, most of us may be Ghanaians here today, but we are Africans at heart. So whatever solutions we are providing here as Pharma Symbiosis, we provide the same solutions in the other African countries where we operate. Next slide. So these are a few partners that we work with. So usually you are used to seeing one pharma company, but in our case, I mentioned earlier on that we are an umbrella company under which several other multinational companies operate. So if you see any team from Sanofi, if you see any team from Asino, you see any team from Sandoz, Sandoz you know very well when it comes to oncology. You see any team from Jamjum, ITW and all that. These are all partners that operate within Pharma Symbiosis. It will interest you to know when there are Ghanaians out there, outside of Ghana, who are also doing so well in terms of producing high quality medicines, we also help them bring those solutions here. So it's not only about representing multinational companies, but we do very well to ensure that if there are Ghanaians who have medicines that would benefit the African population, we bring them here. In summary, last slide. Pharma Symbiosis, as a story is simple. Ours is to make sure that there is no gap between the health system in Africa and the health system in the developed world. Whatever you see or experience in Europe, our job is to make sure that we identify that need. So you see that in the next few months or in the next 1 or 2 years, we'll be adding on new partners, which shows our progressive nature in terms of diversifying our portfolio to ensure that the Ghanaian or the African patient is not shortchanged at any point in time. Thank you so much, and I wish us a successful event.
Right on time. Thank you. Could you take a seat, please? And then Doctors Wadi and Dadzi, please join us up here. We have a 20-minute question time. Dr. Wadi and Dr. Dadzi. Dr. Jakun, I think I've been looking for you. All about the breasts. I so question is open for questions.
Um, one of our ladies, one of our presenters here is missing her handbag. Just at the quiz, black handbag. So if per any table or chair, just look around and get it. We don't want the quiz mistress. It's not that one. This is not that one. Yeah. So in case there's a loose bag around, then. So is it? Oh, it's been found. Okay. Um. So can I take it? Okay. So my first question goes to Dr. Dazi. Oh, don't say ye. It's a simple question because it's did it? It's immunotherapy. So it has something to do with our DNA and all that stuff. And even with breast cancer, we know that the African DNA is so different that we have more triple negative than the rest. So with all these testings that you have done, FDA, FDA is not FDA Ghana. So did it take into consideration the fact that blacks women are women? Generally, we have very different genes, and that can create problems. That things that may work there, not work here. I think we had one with the COVID. It didn't work well in Africa. Yeah.
So, I mean,
Hello, my name is Emmanuel. Please, I want to know after surgery. After surgery, how many years will the patient survive? Sorry. So, number of years after the surgery, like how long would the person
are you
stay?
asking the question based on? Have you heard that maybe after surgery people die?
A
Is that
woman I know, an auntie of mine, after the surgery, she was given 3 years. I think she lived for 5 years. So I want to know if
All right, thanks. Is this question for Dr. Dadzi? Oh, okay. All right. One more question. Hey, Dr. Ansafu, do you have a question? Okay. One more question. All right. In the meantime, we'll just take these two if you are still. All right. Please go ahead.
so? If I may venture into your question, I think that there's a lot of myth about surgery and death. So I think it's one of the myths that if you have surgery, especially mastectomy, you will die, and we see that a lot in the clinics. But then it's a wrong information, and it's wrong because um, maybe somebody had surgery and passed, and so the mindset is that if you have surgery, you'll die. But then again, we don't know the stage at which the patient presented in. We have no clue. But it's not true. It's not true that when you have mastectomy, you die. We have survivors, and there are a lot here 10 years, 15 years, 20 years. I always use my own grandmother as an example. Yes, she had a mastectomy at 38. She's 78. So I know that it's not true that after mastectomy you die. So it's actually a myth. The most important thing, as we've been saying all the time, is that early detection saves lives. And that is what we should push out there. That once it's picked up early, you can have and you get the treatment right at the and quick and effective treatment, you have a good chance of a good life. So it's not true. And
Right.
yes.
Dr. Nyanfo's question.
So yes, so that is a very interesting question. So um yes, the genetic makeup of the African woman is different, and we realize that a number of trials, quite many of the trials that we work with, do not have a good representation of indigenous black women, and And so we import these trials, not having them being done in our setting with our genetic makeup to really say that indeed this is the way it works for us. But in the keynote trials, there was a good proportion of black African women. I wouldn't say representative. So that is one of the things that we can look at, collaborations to involve us in clinical trials so that we can have good representation of our indigenous people, and then we can stand for some of these results. A lot of things that come up, always say in our department that a trial comes up and it's all over the place, and we've been doing it in our center a long time. We just haven't published them, and we know that this is how it is. Even before the big trials come out and mention them, we've been doing them a long time, and we realize that the outcomes are good. So we also need to learn to collect data as a body, as Breast Society of Ghana, in collaboration with maybe Gynecological Society of Ghana.
We'll take you. We'll
Um,
take you.
yeah,
Don't worry.
yes, because it's women. We need to start collecting data. We need to start publishing our trials. We need to start collaborating. And we can only collaborate when we have a good force, we have good local data that we can present to the international body to absorb us into their trials. Yes, and then we also have good quality assurance, because a lot of times they don't involve us because they are not sure of our quality assurance, where pathology is involved, imaging, and all that. So if we are able to get good quality assurance, then we can collaborate and get a good portion of our indigenous Africans in these trials, and then we can really stand up for whatever the result says and be confident that it will work in our setting. I don't know if Dr. Na has anything to add.
In response to the dying after surgery, yes. I just wanted to say that people with advanced disease are more likely to have more extensive surgery, i.e., mastectomy. And so the patients will probably die because they had advanced disease, not because they had the surgery. And please, if you go home, let the story be told. That is not the surgery that causes the death. It's the extent of the disease. There are so many people who've had wide local excisions or even mastectomies for early stage disease, and they are here. So it's not the surgery really, it's the disease.
Mr.
Just a note on the trial. So Dr. Anyamfo's question about how locally representative the data is. You know, usually it's an ambivalent situation where we normally would ask that, is there local representation when a drug is introduced here? But then also there's an interesting conversation whenever pharma companies or researchers want to use the Ghanaian population as part of a trial. You hear all kinds of conversations in the media that they want to use us as guinea pigs. But in the places where these medicines were developed, the population allow themselves to, go through voluntarily, because researchers, there's been very bad experiences in the past for some trials, yes. But transparently as well, they are also very credible research institutions who develop these drugs. So in as much as we are asking that there be local representation of blacks when it comes to these trials, I think today we should also commit to be advocates, so that when these trials are they are looking for volunteers here, the minimum we can do is to either volunteer or encourage our fellow citizens to be volunteers for such trials. So at least when we are asking for local data, we are not again being the same people saying that, look, we are going to be used as guinea pigs when it comes to these trials. So I think it's a two-way street. We just need to find a nice balance of getting this local data, but it cannot happen without our commitment to make sure that this data is collected when they approach us. Thank you.
Thank you. I'd like to add to that. So Dr. Janfu mentioned DNA.
And so when we talk about DNA, it's a blueprint. It determines so many things in our, even behaviors, traits, and so on and so forth. It determines the type of cancer you even get. That's why you can tell that black women have, when it comes to the subtypes, we are more likely to have a certain type, like a triple negative breast cancer, which is all underpinned by genetics. Now, beyond the genetics, so beyond the disease itself, when you take a medication, you metabolize the drug. And those are also mediated by drug metabolizing enzymes. And there are variations in that as well. So you don't have the exact same type of, you have the same gene, but there are slight variations. They're called polymorphisms. And when you look at all these changes in genes, it happens that black people have the most genetically diverse population because humans evolved in Africa. It has other populations, you know, migrate around the world. And if you have most of the genetic studies that influence all this drug development done in Caucasians who are less genetically diverse, what happens is that the data is not representative of us. And Dr. Dazi mentioned that sometimes they have African Americans included in some of these trials. They are representative to some extent because it's a more recent migration from the slave trade, but they're not fully representative. You can glean some data from them because it's quite recent, but they're not fully representative because one, apart from the fact that they have an admixed population, it's not just black, they are mixed with whites, and then you have Native Americans as well. So there are some slight changes in the genetics. So that being said, when you look at different populations, they are characterized by certain differences that come about from the fact that we occupy certain places for a while, and then in response to the environment and so on and so forth, we acquire certain differences. That's why black people, you can see certain characteristics that are not shared by other populations. You can see differences in all these genetic diseases because of this underlying difference in genetics. So I just wanted to highlight that the fact that we're all human beings doesn't mean that we have the exact same DNA. And so when it comes to things that are influenced by genetics, it's imperative that we include our population. We can't keep copying and pasting. And like I said, there are different levels to the response to the drug, not just the genes causing or the mutations causing the cancer itself, but the variations in the genes that break down the drug itself. So there are so many things that give rise to some of these traits, and that's what we call it, like a multifactorial trait. Thank you. All right. All right, please go ahead.
I want to talk about the reconstruction, but first of all, I want to know after.
Please.
I want to know after the mastectomy, how long will it take you before you start the process?
All right, one question. Okay. We process the surgery. Okay, reconstruction. Okay. Another question.
Okay. So this goes to probably the research outlets. We're talking about collecting data, African inclusivity. There's always a bad PR when it comes to research, especially in this part of the world. We know what happened to the malaria vaccine in the Volta region, and then other research that were carried out. It is the reason why some people shy away from it. The ethics of it sometimes is bad. Then the PR of it. Another suggestion that normally comes up is that when you collect data from RCTs for RCTs and other research, the people that you collect, the population you collect the data from, should benefit from the outcome of the research, so that it's incentivized volunteerism. Yes. Then the second question is, well, this is a suggestion. The second question goes to Farmer. Your last sentence, you mentioned that there should be one standard for the whole wide world, so that we don't have a caste system when it comes to seeking therapies. Do we have generic forms of the immune checkpoint drugs? Do you have generic forms of them, or it's only one brand? Just the brand, the originator brands. Thanks.
Okay. Two questions. Any others? Okay. You can start answering them. You have mics.
Okay, I think I'll start with
Yes.
mine.
Thank you.
Timing of breast reconstruction, it's variable. Okay, so from the very beginning, once the diagnosis is made, what the possibilities are and the patient desires are known, we can make a plan. It can either be an immediate breast reconstruction, which is it starts right at the time of the mastectomy. So we're operating together with the general surgeons or breast surgeons to do whatever needs to be done. Okay. In some cases, we do a delayed reconstruction. The type of delayed varies based on what was done and what adjuvant care was given to the patient and what the patient's desires are. Okay. I've had people who waited for their own peace of mind. They've waited a full 5 years before they decided, okay, I'm now mentally ready to have reconstruction. There are those who want it as soon as possible. And even with that, we'll tell some that unfortunately, based on the fact that you as an individual, based on your body habitus and other factors, you need an one type. We need to wait to see if you need radiation, or if you have radiation, we'll complete the reconstruction 1 year after radiation. So it's variable. There's no fixed time, and the treatment is tailor-made for everyone. Okay, I hope that's clear.
So just to make sure I got your question right, you are asking if there are generic versions the the. Okay, okay. So this is just to give a bit of context. When medicines are, we have innovator medicines, right? And then we have generic medicines. So what normally happens is that the innovator is more or less like the mother company that goes through the research and development process to develop the drug. So for instance, when it comes to Pembro, the mother company does MSD, Keytruda. I mean, that becomes the innovator name or the brand name. So once that is introduced, the pharma company has a period which they are allowed the drug patent is viable. So usually you have about say 10, 15 years. Within that 10 years or 10, 15 years, no other pharmaceutical company is able to produce that molecule. So it is when that patent or expires that you now see generic of those products. So a typical example of some of the let me just give you a practical example, like the anti-malarials. We had the Coatems. They were when Ghana moved from the single to the combination dose, Coatem came. After they went off patent, then now you are seeing the Lonats, you are seeing the Malatus and all that. So that's typically what happens. So with Pembro as it stands now, the mother product or innovator is the Keytruda. Once it goes off patent, you will now be seeing generics in the market. So as it stands now, the patent is yet to expire. So once it expires, then you would see a lot of other generics on the market. But you have to also pay attention to where these generics are coming from all over the world. So these are the clarifications just to thank you.
Thank you. All right, I think I'll take two more questions.
Well, if there's no question, then I'll
Yeah.
take one. I thought the other people had questions for them.
They did. for yes.
Oh, but I didn't. Okay. Okay.
Private consultation.
Rita. Oh, okay.
Where's Rita? Yes, Rita. Where are you?
Where's Rita? Okay. Is she
Then
here?
she's not. I
Oh,
hear.
yeah, there.
Please come and have a seat. So please start. Go ahead with your question.
So the Rita question.
Who has the mic?
She's
Yeah.
there.
I want to consult with my question. Hi, my name is Margaret Odamedonko. Okay, I'm a survivor. So my question was to Dr. Christine Buahene. Yeah,
Is she here?
okay,
Okay.
okay. So I wanted to ask, when you were talking about the delays, yeah, you were saying that there's a patient delay and then the healthcare providers delay. I finished with my chemo around September. I had radiotherapy in December. I think it was quite delayed. So I want to know, does it have any effect? Like, I had to be chasing, asking, chasing, asking. So that's one. My question comes with a suggestion. So I'm suggesting, if Kolebu could partner with some private, if Kolebu could partner with some private companies that can also provide radiotherapy treatments, so that it will be seamless. Just after I finish with my chemo, how long should I wait until I start with radiotherapy, so that it clears my doubts and I don't feel like I'm going to die before they give me a date? Thank you.
Thank you. Any questions? Oh,
I think we'll ask the oncologist to help us with this one.
okay.
Okay, they'll come in. Yes. Any more questions?
One last question.
Doc, please, I'll go a bit raw, not technical. Our women are
Take it.
suffering.
Yeah, get it close. Uh-huh.
They are suffering. The ladies who bear with me that sometimes I don't sleep. I've become a counselor, solving marital problems. So I was very happy when Dr. Rita brought the issue on board. But unfortunately, I don't see husbands of survivors here. They are calling her midnight to ask whether they can have sex. This is very serious, very disheartening. The ladies are having pain already, and then you put this kind of stress on them again. So I will ask that next time we are having a meeting like this, let's invite the men so that they will know what is on board. Please, Dr. Rita, I want to use this opportunity to say a big thank you to you for all that you are doing for the ladies. God bless you.
Thank you. There's a question for an oncologist. Yes.
Um, I wanted to mention your name. The person who asked about radiotherapy. So our wish as radiation oncologist is that when you finish your chemotherapy, within 6 weeks you start your radiotherapy. But there are many challenges. You know the presentation she did. I can also give a whole presentation on all the problems for which reason we are unable to start your treatment 6 weeks after you finish your chemotherapy. But let me say that you have up to 6 months after finishing your chemotherapy to have radiotherapy. And we try really hard to make sure that, yes, to make sure that at least within the 6 months, you receive your radiotherapy. The reason is that the maximum benefit occurs within that 6 months period. But I should also say that even though it seems as though it's a very long time, it's much better in Ghana. Elsewhere in Africa, people have to wait a year. Yes, and more to receive their radiotherapy. If we had more radiotherapy centers, it would be easier. But when you have more radiotherapy centers, it means you need more radiation oncologists, and you need more physicists, and you need more oncology nurses, and you need more therapy radiographers. and you need more machines. It's a lot. Hopefully, we'll get to the point where every woman would have treatment facility at least close to their region. But that is the long term. In the meantime, though, we'll try hard at the radiotherapy center in Kolebu Teaching Hospital to make sure that in 6 months you have your radiotherapy.
Thank you.
Thank you. Now, I just wanted to add to that. So, I think our policy makers, our law makers are here. So, I'm going to direct that question. You know, years ago, when our former First Lady, Nana Kunedu Rollins, to the IAEA to make a sort of an appeal, yes, for Ghana. She gave a very strong appeal that we get 3 centers in Ghana, in Greater Accra, Ashanti, and Northern region. So that was what was that. But then we ended up having 2, and this was years ago. We celebrated our anniversary. And that we still have just 2 out of the 3 she had appealed for. And you know, with IAEA and others like that, they expect it's like public-private full sponsorship from there. There has to be the Ghana input as well. So I like our lawmakers, our MPs on the health committee who are here, to kindly take this up. Let this be one of the things you will fight for. At least if we get a 3rd one in the northern region, it will significantly reduce whilst we continue 16 regions getting one in the nearest future. Thank you.
Thank you. I hope you heard. Thank you. All right, so our time is up. Unless there's a pressing question. Okay, last one.
Remember, they said we have to tell the parliamentarians, so we have to tell them. Then they can't have any excuse.
Thank you. I'm Barton, a survivor. Please, I want to know, after taking Arimidex or tamoxifen for 5 years, what happened? What next? Does that supposed to mean you are free from cancer or there is more to do? Thank you very much.
Thank you.
Dr. Dede Medasi.
Who is answering?
Lily, what about that? The lady on the sex.
Oh, you talked about sex.
The lady on the question she
But
asked.
there was no question. It was. Was there a question? There was no question.
No, okay.
Yes. Please.
Yes, so I know that is a very it's a concern for a lot of the patients, because that a lot of them feel that is keeping them, and so sometimes you find patients and you want to take them off and they are still holding so strongly to wanting to continue the Arimidex. Yes, but every decision that we make is not just random. Again, every decision we make is based on evidence. Yes, so the evidence for tamoxifen, now there's benefit for up to 10 years. For Arimidex, there's also benefit, but then it's not a one size fits all. We take a lot of things in consideration before we say you should have it for 5 years or you should have it for more. We risk the patients. So if a patient has is considered high risk, you may take it for more than 5 years. In any case, you also want to balance the benefits versus the risk, because it's not without risk for taking Arimidex. So you also want to balance it. You always want your benefit to outweigh the risk. So if you are a patient that we consider as a low risk patient, you may just have to take it for 5 years and that's it. Based on some other features you have, we may tell you to take it more. But then once you are done, yes, you are done, because the studies show that when the patients were randomized and took it for this number of years, their survival was better. So after that, really, that is it, unless something comes up. I know it's a bit worrisome being taken off, and they feel that that's what is keeping them. We have those discussions from time to time. But then, if that is what the recommendation is for you, then that is it.
Thank you very much. I appreciate you. Thank you. I think you have.
Shall we do it again? Okay. So we've come to the last part, which is the business meeting, and you can check the details on page 34. Page 34 is where we have the detail. So you are all, you can all stay. It's very important because we want to hear your ideas. It's only voting that you can't vote, but you can contribute. Oh, we want to hear your ideas, and maybe there are some things that we want you to take to Parliament. So we tell you here, and then we'll bring a letter. No, no, no. I said, oh, when is our election? Yes. But you can still pay your dues now and vote. Okay, so I'll hand over to our president, Anna.
Thank you very much. We'll just set up quickly and then Gina, Lily, be by me. Gina, Georgina. Can someone kindly get Georgina? Hello? Okay. Thank you. So we are all welcome to the business meeting of the Breast Society of Ghana. We've allowed everyone to stay in, so that's the only way we get buy-in. We also, people are interested also in joining. I'm sure not all of us here are registered members of BSoG, but at least when you sit in and you see what we do, you'll be motivated to join us. In other conferences, other jurisdictions, normally when it's a business meeting, it's just the paid members, registered members who actually stay. But this is being done on purpose. At the right time when we have the elections, it's just the BSoG members who will pay, who will do the, vote when the ballot sheets are shown. So we're going to start with the president's address in a PowerPoint format. Briefly to see what briefly, just to have an idea of what we have gone through since we had the last AGM in August 2023. Can you kindly, or should I change the slides? Maybe you can give me yes, so I can change the slides. So this is just a pic the executives at the last AGM. That's a picture we took from my far left, Dr. Ahimfo, then Executive Secretary Gina, myself, Treasurer Dr. Nsafo, Secretary Dr. Lily Pamka, and Vice President Dr. Akwese Nyamfo. Next, please. So you see some pictures of excited, happy BSoG screening and outreach committee members at a screening in Tamale. Next. And this was a screening done at the Tuesday market. So as you can see, the team has been very busy. This is a picture we took at the surgical block with the Ghana Commercial Bank, who visited us, and they are our main bankers, so they collaborate with us. Next. That last year, briefly, my outline. October 2023, Breast Cancer Awareness Month. We'll be looking at the function of the BSoG office, Roche Media Campaign Collaboration, BSoG Pfizer grants, reports of committees. Next. The strategy plan review, October 2024, Breast Cancer Awareness Month, BSoG updates at this upcoming elections, collaborations and sponsors. So that's the outline. Next, please. So after the August meeting last year, we successfully had a launch of the Breast Cancer Awareness Month that was held at the Christ the King Hall in Accra. We also had education and screening activities throughout the month, media advocacy and education on breast cancer. We were supposed to have an October walk, but that was cancelled because the day clashed with the burial of the Queen Mother of Accra. So we had to cancel that, but hopefully this year we'll be having it next, please. Our BSoG office, like I mentioned last year, was inaugurated. Unfortunately, the patronage has been low at the office, but we want to encourage members that our office is at the Nagrat House building, room 503. So there's a lift there that will take you all the way up to the 5th floor. And Gina is there on Tuesdays, Thursdays, and Fridays. Monday, she works remotely, but the office line is always busy. It's a very easy number to remember, 055-999-4747. So you can even commit it to memory and remember. So we welcome visitors, do administrative activities there, correspondences. She also organizes counseling for members and then meetings as well. We've had a few meetings using the Nagrat conference room. Next, please. So this year, starting from sometime last year, Roche Pharmaceuticals came up to BSoG and said they wanted to collaborate with us, do some media collaborations for the whole of 2024. Because what normally happens is October is when we have the October Awareness Month. But this time we wanted the story to go beyond October throughout the year. So we had a team of members, including Dr. Nyamfo, Ahimfo, Gina, Kumajaga, and Riza Sambu, the advocacy committee chair, to join the Roche selected team to actually design a program for this year. We had the preliminary meeting, came up with the ideas, and this was put together. So a budget was finalized and collaboration agreement signed. And the first and second quarter engagements have started rolling out first, and we are now going into the second as well. So far, unfortunately, we only have 3 regions which are on board. We have 5 chapters. The 2 other regions have not yet started. I think the Ho and Tamale. But we're hoping that very soon we'll also have the TV engagements there. As you notice, some of us have already been on air. Myself and Gina have been to Unique FM twice, GBC, and others have gone to Dr. Che, and others in Kumasi have also gone on air. So we are hoping that the message goes across. And this time we're also shifting focus, not just on signs and symptoms and causes of breast cancer, but we're trying to get policy as well involved. What change, what can be done for the patient actually going through the journey. That's why yesterday we focused on the patient's journey, because it's a different thing knowing you have the disease and all. And there are some people who are diagnosed, and beyond that, nothing happens because of financial issues or remote, transportation matters. Yes. Then BSoG also was able to get a Pfizer grant led by myself, Dr. Nyamfo, and a team of us. Professor Cleglamte came up and said we should, consider a grant that had come out to, apply for that and see whether BSoG will be able to get that. So we took up the challenge from Prof and I formed a committee, and we've been able to, we applied for the grant and we got the grant. So we have a $108,000 grant, which there's the PI team, like I said, myself, Enyamfo, Dr. Nsafo, Dr. Mervyn Ajiman, Florence Dede, and a number of us, Dr. Bowen and co. We are all part of that team, co-PIs on the team. So we did the IRB application for the study in 5 regions, and it's a study on destigmatization, which is really important. Especially yesterday, you heard Dr. Abudu Atika's lecture, a presentation, and the impact of what stigmatization is doing in breast cancer. So that is really what we are doing. It's an empowerment study. It's a 2-year study. So 5% overhead costs has been paid into the BSoG account. Our treasurer has ensured that. And the study is being rolled out, like I said, in the first 5 regions. We have 4 phases. We are on the second phase, more or less, concurrently running the first and the second phases now. We've done a lot of survey, questionnaire administration to patients, survivors, caregivers, and all. We're also looking at focus group discussions now. Next, please. So reports of the committees. We have 5 committees in BSoG. We have the finance committee, which is chaired by our treasurer, Dr. Josephine Nsafo. The organizing committee, which is chaired by the organizing secretary, Dr. Charles Ahimfo. Research committee, chaired by Dr. Emmanuel Tego, who is here. Advocacy and publicity, chaired by Riza Sambu. And screening and outreach committee, chaired by Enam Sechofia. Next, please. So the finance committee has rolled some sponsorship packages, which have been worked on by the committee. Recommendations for remuneration have been done. Fundraising video has been designed and shared. I'm sure we've all seen that on the BSoG platform. And yesterday, at the end of the day, it was also, we also had the fundraising video. So we encourage all members to share that video. We can post it again on the platform, share it as wide as possible for people to be encouraged. There are some people who, like yesterday we heard, they want to do something, they want to sponsor, but they really don't know where to go or what to do. So if you send this out, it will give them ideas as to what to do. And another aspect which has really been a challenge is the payment of dues. It has really been a challenge. And I'm sure my treasurer will talk about that when she comes up. So we've been sending regular reminders for payments, even much more than we were doing before. I know sometimes it's difficult. I've had to collect dues at my doctor's flat before, and I can tell you, even among the doctors and pharmacists, it was a real challenge. But I think that's something that we need to be encouraging ourselves to do. Next, please. Next, please. Yes. So the organizing committee we have 6 BSoG regional chapters in the North, Upper East, Upper West, and Savannah, Ashanti, Bono, and Ahafo regions, Eastern, Volta, which includes OT region, Central, and Western. And these platforms have enhanced information dissemination to members across the country, and there's been increased regional participation. So for all the chairs of these regional chapters, we want, because we didn't want BSoG just to be centered in Greater Accra region, we want to have other members from all over the country. It's your duty to encourage those in the north, in the western part of Ghana, central, and in the Bono and Ahafo regions as well. They've been having online updates on early detection of breast cancer, which happened for the regional chapters prior to the October Awareness Month last month. And I hope it will happen also before the 2024. We've had 2 quarterly webinars so far, which has been led expertly by the organizing secretary in the organizing committee. Next, please. For research, we've had 4 major research topics which have been proposed by the committee chair, secretary, and members. The topics include determinants of late breast cancer presentation and impact on management outcomes, a multi-center study in Ghana. Then a systematic review of the psychosocial factors affecting breast cancer diagnosis and management in Africa. So I think for the first topic, Abigail Ninson is the one who is the PI for that study. For the systematic review, Dr. Bowen is that, and these are all research committee members. Impact of Herceptin on quality of breast cancer care in Ghana, retrospective study. I'll be leading that paper. An assessment of intervention navigation programs and quality of breast will be led by Mary Idrisu. So these 4 research topics, we've already started outlining if there's any interest from anyone to join any of these as well, since it's a BSoG activity and research plan, you can also come on board. See the research committee chair. Emmanuel, can you raise your hand? And our secretary is Dr. Ebenezer Wiafe. Okay. So then, Roche Pharmaceuticals has reached out to collaborate on the Herceptin study, because just about when we were starting to design that, they said they actually wanted to find out what the data, on what the outcomes of the rollout of the Herceptin on the insurance has been till date. So they're trying to get that. So we'll be working with Roche Pharma on that study. Next, please. For advocacy and publicity, number of things have also been rolled out. We expect a little more enthusiasm from the advocacy and publicity committee. But we've had a BSoG official YouTube channel, which is now ready. Members, and a lot of it has been spearheaded by Gina. Members being encouraged to subscribe to the YouTube channel. So look out for Breast Society of Ghana YouTube channel. Videos of survivor stories have been worked on. Dr. Nsafo has worked with Gina to ensure that that happened. And these will be circulated via YouTube. Some of the videos were streamed yesterday. I'm sure you heard some of them. Some editing also has to be done for many more to be put on the YouTube channel. We have formed information leaflets and flyers, which was also led by Gina and Josephine Nsafo. And copies have been put in your conference bags. So I'm sure if you look into your bag, you see a leaflet or a flyer, which is there. And that is the leaflet, which we had said at the last meeting we're going to make available for October. So now we have a customized BSoG flyer. And we're also working on information booklets for the grant research, which is also being led by Josephine, Dr. Dede, Prof. Clegg Lamte, and a small team to get some information. So the grant team members are writing in simple language various aspects of breast cancer. The whole 9 yards of it, but such that any child who picks it up can actually read that. So that is also at the printers, right, Josephine? Ready to go. Yeah. Okay. So for the screening and outreach, Enam, are you here? So Enam will tell us. She's the screening committee chair together with her secretary, Priscilla. I'll say, Priscilla, wave. Great. So Enam will tell us briefly screening and outreach committee
Okay, my name is Enam Sechofia. Please, can you show my slides? Yes, please. Okay, so the screening and outreach committee were given the mandate to start work in October. After a forum like this, we were given the mandate to start work. Um, um, by way of introduction, our mandate was to organize regular screening activities, to create awareness and organize campaigns, coordinate screening activities, and give them periodic reports. So we started in 2022. In 2022, we're having letters coming in for us to organize a screening. Unlike in 2024 currently, where BSoG is able to organize their own screening by funding it themselves. From 2022 to 2023, we were getting letters that come in for us to organize the screening. So in 2022, we screened a total of 2,468 women, and 97 of them had abnormalities. This screening was done among schools. It was schools, organizations, churches, and then FM station. Please, you still have challenges in showing the slides. Okay, so the FM station we went to was Sunny FM. And then we did one for the organizations included Air Cote d'Ivoire and then ECL. That was done in 2022. Also, we screened members of the Ministry of Health. We carried out outreaches in some churches and some schools, and all amounted to the number I quoted. In 2023, a repeated outreach was carried out in a number of organizations that also invited us to carry out screening. But in 2023, we had a decline in the numbers coming in for requests for us to come to do screening. However, there is a major turnout in activities, as BSoG got some money to be able to sponsor screening activities. And this way, we were able to break boundaries, meaning initially the screening activities were held only in Accra. The only one that was out of Accra was in Kumasi, and that was just in 2022. 2023, we didn't have any requests coming in to do any outside Accra work. But when BSoG got sponsorship, we've now been able to carry out screening activities in Takoradi. We've been to Tamale. We've been to the Volta region. Volta region, we were able to do 3 different sites, which amounted to about 317 women being screened in Volta region. And then we came back again to Greater Accra at Tuesday Market, where we were able to screen a lot more women. So these are pictures showing you of some screening activities that were done. What's on your screen right now is Takoradi. What we did was BSoG members that were in the outskirts of Accra. We contacted them and then asked them to come up with a budget for screening. And this how come we were able to make it possible for it to happen. So that's in Takoradi. Yeah, so this right here is in Tamale, where a BSoG member was contacted, and then she also helped to make this screening possible. Here, it was carried out in the Central Market, Assemblies of God, and about, I can't see the figure well, 61 women, 102 were educated, and then 61 were screened. Please roll up. Yes, so this is the screening activity done in Ho. Here, we had a significant number of people turn up because we conducted it in different areas. We saw about, we went to Ho, Ahoy Community Center, the Fiave EP Church, the Fiave Health Center. And even with this one, there was a media engagement. So we went to the radio center and then had some education before the screening started. Now here is another one that we conducted in Accra. This was done in collaboration with the National Radiotherapy Center. This screening was done at the Tuesday market, where we had a survivor also come in to share her story. And significantly, some women turned up for the screening. So that's a picture in your view now. Yeah, so the last one currently was done in Pram Pram. And this was done on the 16th August. And it's also saw a significant number turn up. We've made a lot of achievements. We've been able to expand outreach efforts by successfully getting to diverse populations. We've been to the market women, we've been to corporate organizations, and then we've been able to collaborate with other health care professionals in that where we are able to conduct screening, we may not be able to see the patient afterwards. So we contact the hospitals near so that they are able to see our clients for us. We've been able to engage volunteers. We've had people who don't know anything about screening or even breast cancer. We've been able to recruit them, to train them on site as to how to be able to identify lumps or abnormalities in the breast. So we've had some expanded efforts. I must say, these are just a few of our achievements. So I'll move on to our challenges. The major challenge is that some women are unable to afford for a simple mammogram or ultrasound scan if you ask them to do it. And so all our efforts are thwarted. What's next? We are preaching early detection. We are preaching find these symptoms, find these signs early, and then come to us. But where the person is unable to do any investigation for you to be able to make a concrete diagnosis, then it ends there. We are unable to reach our efforts. And then Breast Society itself does not have say bed screens and other things for us to carry to places to conduct screening itself. So then we lack teaching aids. We don't have teaching materials to teach, to bring to bear what we are saying, because most of these educations are done in the local languages, and people will appreciate it better if you show them pictures and all of that. Thank you very much.
Thank you very much. And could you kindly go back to my presentation? Thank you. So I think we've highlighted for Breast Society of Ghana, screening and outreach is very important part of what we do. So I'm glad that we've been able to hear what the screening committee is also doing in that area. Can you please go back to okay. Next, please. Next. Okay. So the Breast Society of Ghana had a 5-year strategic plan, which was rolled out and ended this year. Means that we needed to review the plan and look at the next 5 years. So that was done. We had an in-person meeting. The executives, together with the council chair, met overnight at the Assemblies of God on the 21st and 22nd of June, and actually had a very successful meeting reviewing the 5-year strategic plan and detailing plan for the next 5 years. So we will present that briefly at the AGM, and then it will be adopted. Next, please. The BSoG stakeholder meeting, as we know, was held here, 29th, 30th. Normally, we had a 1-day AGM, but this time we had a 2-day AGM, which has been successfully rolled out. And I'd just like to say that one of our survivors, who is also a development expert, Miss Efia, was brought on by Dr. Nsafo, and she has been very helpful together with her team to do this, and she's also helping us with October celebrations as well. Next. So for 2024 Awareness Month, there are a number of things ahead of us. We have written letters to the banks, just in case. Yesterday there was a Bank of Ghana rep here. We don't know. We've written letters to the banks, and we are hoping, and to MTN, we're hoping that they can drape the roundabout in the city capital for us in pink. Our hopes are very, yeah. Someone said hi. But we are hoping that they will heed our call and at least do that. We don't expect any elaborate decorations like at Christmas, but at least for the pink ribbons and all to show in collaboration with BSoG. We'll also have the media lunch, like mentioned yesterday, here at Accra City Hotel, who is now one of our major sponsors. And we'll have a 1,000-man walk. So we're trying to get on board as many people. Yesterday, our chief from Abola said he's going to get his women together within his area to join. We are hoping that you also bring on board other members, men and women. We're going to have the parliamentarians. We've been told that if we are fortunate, the Speaker of Parliament will be joining us as well to walk the streets of Accra to talk about breast on the 26th of October. So be looking out for that. Miss Efia is helping us with that as well. Next, please. Next, please. Okay. So other important updates for us to know. The Medical and Dental Council registration, we did that for the webinars and AGM. We were able to do that alone for the physicians now. But in the future, we have collaboration with WCEA, which is a World Council for Education Alliance. So they will be moving forward, also helping with registration. I mean, because they have already registered with the Medical and Dental Council for pharmacists, nurses, and hopefully for others as well. The Ghana Commercial Bank, we initially had to, request from them, because for our dollar accounts, they were taking off charges regularly from it, and that would have significantly reduced our funds within a period of time. So they met and discussed this and gave us that concession. So that was removed from the account. So it's important just for us to know what they are also doing. Updates of the BSoG webpage are being worked on. We've had delays with updates being put on, but enterprise computing, yesterday they were here, we've had that discussion, and they have promised that they are going to do that, so that anyone who goes to the website can see immediate updates of what's happening, including even the updates from the AGM. We've tried to contact a lawyer to discuss the possibilities of the BSoG Foundation to help, in various aspects, including treatments for patients. So we're working on that, and hopefully the next executive to be elected will move that forward. We had a constitution review committee. The first constitution review done was led by Prof. Cleglamte and a number of us. That was when BSoG was formed. So now we are 6 years old. We've looked at the constitution led by Dr. Augustina Bedu Pepra and all the secretaries of our committees, including our secretary of the executives, to actually review that committee. So we'll review the constitution. So we'll be looking at that, and then if we accept the recommendations they have, we adopt that. Next. We have upcoming elections. The current executive have exceeded the mandate of 2 years. So we're going to be having elections. Now, and our electoral commissioner is Dr. Florence Dede. In the course of the business meeting, she will take up. We sent out announcements and nomination forms, and nominees where we received nominations. So those are the forms on our ballot papers which are going to. So we won't be requesting for nominations here. So just be the ballot papers shared out. And paid BSoG members with red tax, and even those who don't have paid members, will be eligible to vote. Next. So collaborations we have had with BSoG, Cancer Support Network, Mod Local Foundation, Safe Haven Ghana, Embrace Society, the World Continuing Education Alliance, Smith University College, Global Media Alliance, who have also reached out to us, Celebrity Golf Club, and Accra City Hotel. We have a number of sponsors. Next, please. So these are the list of sponsors we have. I've mentioned them before. But MSD, Roche, Pfizer, Pharma Symbiosis, AstraZeneca, Pathology Without Borders, Enterprise Computing Limited, Sonotech Ghana Limited, Accra City Hotel, Deng Pharma, Asasi Radio, DDP, Ghana Commercial Bank, Ghana Ports and Harbour Authority, and Philips Pharmaceuticals. Next. Thank you. Okay. So that's the end of. Thank you. So I think we'll move on immediately because of time to just go on to the minutes of the last AGM 2023 AGM minutes, please. So I'll just briefly scan. We've put the AGM minutes on the Breast Society of Ghana WhatsApp page. So our secretary put that up earlier. So I'm hoping that at least some of us have already had a look at that. So I'll just quickly go through that, and then we've selected the action points from the last AGM on a different document. So then we'll look at that quickly, what's been done and what is yet to do, and move on. So that's going to be fast. Can I have the 2023 AGM minutes, please? That was the second document I shared with you. It's a Word document. A Word document. No. Yes. Okay. Is it possible to increase the font size? Yes, because I don't think people can see this. If you can just scroll like you did for enams. No, this is not working. Can you just try and scroll the Word document? That would be better. This is going to be almost impossible to see. So we held the last, at the 4th annual general meeting, The business meeting was on Friday, August 18th, from 3:30 to 5:15 p.m. The venue was the Botio Auditorium, Alisa Hotel, Northridge, Accra. All executive members were present, and we had other members also present. The document is on the WhatsApp page because we'll have to adopt the minutes. So kindly look at it. Maybe to be better that way. Dr. Dede gave the opening prayer at that, and then there was the welcome president's address. A few of the things that came up was reconstitution of the committees was spoken about, office inauguration, I mentioned that. Then the breast cancer social media awareness campaign was also discussed, and Gina presented that. That was done on Facebook, Instagram platforms, and we gave the details and the scores that we had. Then the registration of new executives and change of signatories, which had been also spearheaded by Gina, was also mentioned. Reports of the committees was the screening committee, advocacy, finance, research was also discussed. We spoke about the post-Pink October screening outreach challenges that had have some of them which Enam has mentioned again. So those ones were outlined, and recommendations were also given by the screening team. So some of them were inputted in the 2023 October cancer awareness campaign, but there's still others which need to be worked on. The strategic plan and actions for the year were also outlined, and in the next document on the action plan, we'll actually look at what has been achieved and what is yet to be done. Activities for October 2023 were also outlined then. Patient-centered themes for webinars, Pink October launch walk, media engagement, annual screening, and a Cape Coast walk and awareness was also mentioned. I think that was done, but the one in Accra couldn't happen because of Akwe mother's funeral. Patient navigation and data collection, I think I mentioned there that Roche had ended that agreement with BSoG, and for the navigation, Embrace Society was now handling that, and Roche themselves were handling the Herceptin data collection. So the collaborations as at last year were the WCEA, Lynn Perrow Foundation, UK, Embrace Society, and a film group who wanted to capture the story of a survivor, the journey. So review of minutes was done. The minute was moved by Dr. Amadia Tete and seconded by Madame Alberta Emisa Roxin. Matters arising from the minutes discussed. We had difficulties with dues payments that was discussed, and it was proposed that members, the amount be increased to 200 Ghana cedis, which was accepted, and for survivors, 100 Ghana cedis. And we also encourage that members adopt a survivor and pay the 100 cedis for that survivor. We also mentioned that there was collaboration with banks to drape the roundabout. So that was from last year. Unfortunately, it didn't happen in 2023. We're hoping it happens this time. We have a lot of faith. So if you are here and you happen to know any of the banks, Zenith Bank, Cal Bank, APSA, Gina, any others, MTN, which other bank? Yeah, any of the banks which are responsible for the major roundabout, please push that agenda for us. Dr. Nsafo presented the accounts for BSoG and any other business. Dr. Ahimfo, that was when we launched the survivor wing of BSoG. So Dr. Ahimfo provided a cake, which was a surprise for our survivors. We had a lovely time last year. Closing motion moved by Dr. Bernard Seshi, seconded by Dr. Amadia Tete. Closing prayer was given by Alberta Emisa Roxin. So that was in brief the minutes for last AGM 2023. I hope some of us have been able to have a look at it on the platform. So I would like to ask if someone, the minutes have been signed by myself and signed by the secretary, Dr. Lily Pemka. So if someone can move for acceptance of the minutes and a seconder, please. For members who were here at the AGM last year. If you were here 2023 and you were in the meeting, can we have someone move? Dr. Dede, thank you very much. Dr. Dede has moved. Any seconder, please? Madam, you were here. Please, your name. Okay. Madam Barbara Doona. Thank you very much. So can we have the next document, which are the action points from the meeting? So we quickly look at that. We've highlighted what we've been able to do and the few that are left to do, and then we can bring that to a close. So action points, yes. If you can please increase the font. Can we see? Can you see? Okay. So in order to speed things up, our secretary, Dr. Pemka, did this. So the action points were put together. We looked at all the important things, so we have them, and then we got them on a document and decided to start highlighting. So we've highlighted in green what we've been able to achieve, and in red what is yet to be done. So the first thing is membership payments and dues. We're to outline benefits of fee-paying membership to encourage payments, increase membership dues to 200 cedis from January 2024, encourage members to pay 100 cedis for survivors who cannot afford to pay, and that has been done. Collaboration with banks and corporate organizations. So we said to collaborate with banks. We've actually gone out with our letters, so we've considered that done. We're just hoping that it will actually be implemented in October by the bankers. Encourage members to seek support from corporate organizations. Finance committee has worked on that. We've got a package with different gold, platinum, etc. sponsorship that has also been sent out. So that is information is available if you will use our members to move the message forward. So if you know any of these organizations, kindly let us know. Let Dr. Safo know, or whoever will be our treasurer, to then move the message forward. Registration of new executives and change of signatories has also been done to ensure a smooth process for registration and signature changes. Registrar General Department, Gina has worked on that as well. Strategic plans and actions for the year were to review and update the BSoG strategic plan has been done, create a survivor group which has been done, pursue a BSoG-led grant which has been done this year. We've actually applied for 3 grants. After the first grant we won, we applied for 2 other grants, but unfortunately we did not get those ones. But we are not perturbed. We will continue applying for grants. Proceed with planned activities such as webinars and screening, which is also ongoing. So those are achievements from last year's matters arising. Membership and commitment involvement. So members were encouraged to consider joining any of the 5 committees, and we had quite a number of members joining. In fact, even today, someone has joined one of the committees. So that is actively going on. We'd just like to ask the committees to be more involving, so that at least we can move things forward. We are the ones who will hold up Breast Society of Ghana. No one will do that for us. So let's all get on board, get involved, and move on. Office visit and utilization. Members were encouraged to visit the BSoG office, which was inaugurated 17th February 2023 at the Nagrat building. And Nagrat has been very gracious to Breast Society of Ghana. So the office they've given us, the dues, the charges are not up to what they charge for everyone else. They really have what we are doing at heart. So the Nagrat CEO or director has, been collaborating with us. And so we are very grateful to Nagrat. Strategic plans and actions for the year. To develop a harmonized breast cancer leaflet, awareness leaflet, that has been done, like you see in your bags. and share survivor stories on BSoG YouTube channel. So the survivor stories, some of them are ready. You heard them yesterday. A few more are to come on board, and these will be uploaded onto the YouTube channel. So the things outstanding, which from the last AGM we have not been able to yet achieve, is formation of a foundation. We tried to get in touch with a lawyer. I'm sure that hasn't been fully successful, but to create a foundation to support patient treatment with assistance of a legal person. So we're hoping that the next executive can take that up with the BSoG Foundation. Financial management, we were to consider charging conference fees for future AGMs for members in good standing who will be eligible for discounts. We almost implemented that this year, almost. But because we had good sponsorship from MSD and Roche, we decided as executives to hold on together with the council chair to hold off that. But we realized that because of the cost, if we want to have a very comfortable meeting, we need to also put in something. So obviously what will happen is if you're a BSoG member, you will have discounted fees. But if you are not a paid member, then you will be paying the full fees. So bear that in mind. In the near future, or probably from the next AGM, that will come into full force. Post-Pink October screening outreach challenges and recommendations to upgrade screening venues for better privacy. Those were recommendations given. Sometimes for some of them, it will actually have to depend on where the screening is going to happen and all. But these have been taken into consideration, and for some of them, they are yet to be actually implemented. Ensure timely intervention for suspected cases. Provide training on breast clinical exams for health workers and improve communication effectiveness. I think some of these, some of these have actually been done. The training on breast clinical exams, etc. So I think we can actually move some of these to the green part. Then the strategic plan and actions for the year. Develop a recommended screening guideline. The screening committee is to work on that. That has not been done yet. So we are encouraging screening committee and outreach committee members to have a screening guideline. That is a mandate, one of the mandates of the committee, so that we can, apart from the information leaflets, people know exactly how to screen, something to guide members from Breast Society of Ghana. And then finally, social media awareness campaign. We mentioned that to emphasize sustained educational content creation and distribution on social media platforms, and to encourage members to engage with and contribute to social media posts. So that is one thing that we really haven't done very good at. So we still have it in red on our action points here. So we're hoping that each of us, we are all, some of us are more social media, some of myself, I'm one of the least social media Twitter people. I mean, once a while I'll just forward something or like someone's thing, but I hardly ever go there. But I think it's something we need to encourage ourselves on. Some of you are really, social media savvy. Yes, so if you are, please, everything we are doing here, including what is happening here, just post on your social media platform. That way Breast Society of Ghana moves far. Thank you very much. So
Any questions?
sorry, I've had to rush through this because we have to go for lunch, and we
People are
need
hungry.
to finish with 2 or 3 more items. So I had to go through quickly. Yes, sir.
Yeah, thank you very much. You are doing very, very, very well. I just want to understand plans of maybe scaling up or some kind of decentralization. I know as a bigger umbrella, you are there, but to support maybe at the regional levels or whatever, you may have people who want to also belong to the group. That you find that structure. I mean, so that at the regional levels, your society can be visible there. But then it can then be controlled at the national level. Just a suggestion.
Thank you very much, sir. We actually do have. We have regional chapters. We actually mentioned that earlier on. We have regional chapters in the northern region, in western, Ashanti, central, and Volta. So these even we have chairs of those, and it's under the organizing committee. So our organizing secretary has been working on that. And some of them are actually here. Some of the chapters are here. So it's something. A chapter, yes. So then the list is behind. We have the chair of the committee. I think we didn't add contact numbers, but Dr. Ahimfo can get you the contact. He's noted it so that you can communicate with the chair of the northern chapter. It's Upper West, Upper East Savannah region. Thank you. Okay, so if there are
no questions, then we'll move on.
Yes, so we move on to the strategy review. If you good. Kindly, and Dr. Ahim.
Is the review, so Anna. So we can even just put it up there. We'll mention the main titles so that people will see the titles, and then later they can read. And trust us is good. So vote yes, and let's go and eat. Oh, just the title. Yeah, give us the big title. Yeah. So the first one, BSoG becomes a leading organization. We want that the moment you type breast cancer, Google, BSoG's name should come first. That's the whole idea. That the moment anything breast, BSoG's name should come first. That's why Hannah was saying that all those who are internet savvy, social media savvy, should be liking and the rest, so that with Google, the more you like, the more it appears, the higher it goes on the advertising scale. So we want people to do that as much as possible, so that BSoG, the moment somebody comes, everybody comes to BSoG first before any other organization. And over here, it's not visible. These are 3 strategies that we've proposed that will make. The second, yeah, this is the second phase of it. The first phase was successful, so this is a build up on the second phase. So our second objective is, yes, management, right? So management starts from normal all the way to the very bad. So we want to be the leading organization where it comes to management. When everybody has any problem, they should call our line first, because that's where you get the most reliable information. So that's our second objective, so that anybody with any, because for those who are in the other room, we were told that most people get their information from their friends and the rest. Even after the doctor has talked, they still go to their friends, right? Because of the block. They I'll explain, but then we want it to be that any question you have, just go straight to BSoG website. Jenna is always there to receive you. Next objective. After is here. Or you want to ask questions per objective? Okay. If they could blow these up, you'd have seen it. Okay, objective 1, please. Between 1 and 2, eh? What exactly are you looking at that you still is not clear?
appreciate where you are coming from. I think we need to just rephrase. Rephrase. It's objective number one. But we can't see. Can we? Is it possible to blow this up? Yeah, Dr. Fojo, I think we need to rephrase objective number one. Yeah, because we are not a hot. But I think when we can blow this up and we see that the strategies there are to encourage collaborative research. I think supporting the guidelines. Uh-huh. Exactly. So we need to edit that. Uh-huh. So we are proposing this, taking notes before the strategic reviews is adopted. So thank you for that. You've taken note of that. So we'll rephrase the number one.
And if you had, and perhaps I would have discussed it. So yes, we go. So you can see it's a twist with your suggestion. Okay, let's move on. Objective three. And it's not something we are adopting today. So today we are reviewing it. Yeah. One. Okay. Please go back to objective one. Leading source of information for breast care management in Ghana. Leading source of information for breast care management. Ah, leading in breast care in Ghana. And it still meets. Yeah. Okay, so Gina. Yeah. Great. Number two, please. Yes. So awareness. Leading awareness. Since we will give the right information. To and improved survival outcomes. Yeah. It should be what? This one there. So so the way again and fancy people are the way again and fancy people are teaching us the English. Okay, number three. Number three. Uh, so this oh it was there. So if people had something. Okay. So this improve. So this way is improve. Uh-huh. So oh sorry. Then typo. So we are building human resource capacity, and then health insurance company that's engaging them so that they can do more than they are doing now. That's why we brought the NHI guy here. Next page. Okay. Oh, thought we had gone. Go back. Objective 2. So now we are going. Okay. Every Ghanaian should know about breast cancer, and then improve women's participation in regular breast screening. No, so, okay, no, go to the next page. Hold on, no. The third objective. Yeah. Standardize the practice of breast care management at all levels of healthcare. Over here, we are just trying to see if we can bring out. Oh, okay. No, that's the general one. Then the specific one. So, wherever a report is given, it should be standard, or everybody should know that this is what it is. That's the whole idea. That's why I want to train all those people. Okay. Objective 3, please. So this is to improve access. Right? Screening should always be easy, affordable, and accessible. So that's what we are talking about here. Improve access to that. So build a human resource capacity so that it can be everywhere. You can walk in and do it. And then when we detect it or diagnose it, that's where the money part comes in. So that's where we want health insurance companies to step in to help. Right. Next page, not objective. Okay, that's so too. So that's for objective 3. Any questions? Okay, then number 4. Advocate for development and implement of appropriate breast cancer policies in Ghana. So this is where we have to create a policy and then give to our policymakers to see if they can help us. So we have to review the guidelines now, and then if we see anything, we advocate for new national screening guidelines, and then fair distribution, equitable distribution, which we discussed yesterday, for all patients. Okay, then the last one, educate, organize survivors and interest group to support the cause of breast cancer. And the first is what we wrote a project for, destigmatization. In the north, I hear you can't even go to the market and buy. They won't sell it to you. So you have to go at night to the person's house secretly. Then adherence and patient navigation. We actually wrote another proposal to AstraZeneca for patient navigation. Unfortunately, we were not successful with the grant. But it doesn't mean we are stopping there. We are still doing it. We just wanted it on a much bigger scale, but it didn't happen. So that's where this objective 5, the objectives are, the aims are. And there are only 5 objectives for now. Not only, but there are 5 objectives. Okay, so are we to approve it? Or you want to read it? Okay, so it's been sent to your, just read it. Can't you approve virtual? Everything is virtual now. So maybe after 2 weeks, they will put a poll here. All those highs and knees. Or yo-yo. Yeah. Okay, so thank you so much. We expect contributions to make it perfect. We are not assuming perfection, but it's good to involve everybody to make it perfect. Thank you.
They were the members of the review committee. So Dr. Pemka will quickly take us through that. We have the elections and then we are done.
All right, thanks. I'm going to keep it short and sweet because I know people are hungry. I don't want to get angry with me. So we reviewed the constitution. Most of the changes that are quite actually cosmetic, and a couple of typos that we corrected. But the major change we made were concerning the objectives. So yeah, so like I said, some of them were cosmetic. So in this part basically just rearranges the addresses and everything of BSoG in a table.
Can you please increase the font size, please?
In a table. I can read it out. The part that we actually.
So they made some track changes where
Yes.
the recommendations. So maybe you can just.
I can just read that. So prior to this review, okay, prior to this review, we had three main objectives: the society, one, to influence standards for the management of breast diseases in the country; two, to be involved in breast disease research and education; and three, to carry out breast cancer advocacy for management in terms of awareness and early detection. So what we've done is to kind of expand them, considering the kind of work we've been involved in the past 6 years when it was first written. Currently, we have 8 of them. And so I'll read them out to you. So one, to advocate for the availability of breast diseases standards for diagnosis and management. Two, to actively participate in breast disease research, clinical trials, and education. Three, to engage stakeholders in the provision of quality and cost-effective medications for the management of breast diseases. Four, to promote the early detection of breast diseases through awareness creation, enhanced community screening, and the implementation of early detection interventions. Five, to contribute to the education and training of healthcare professionals in the screening, diagnosis, and management of breast diseases. Six, to support and collaborate with patient advocacy groups to ensure the voices of breast disease patients are heard and considered in the development of policies and treatment protocols. Seven, to foster international partnerships and collaborations with global breast health organizations and research institutions to enhance the exchange of knowledge, resources, and best practices. And then finally, to develop and promote guidelines for culturally sensitive patient care, ensuring that treatment and management of breast disease are aligned with the social and cultural context of Ghanaian communities. So it basically just expands on the. So yeah, that's it. That's the list that I'm reading out. So like I said, we had those three. So this basically just gives it a bit more of context, expands it a bit, and then incorporates what we've actually been involved in, as well as some of the new strategic plans we came up with to achieve our strategic plans for the next 5 years. So those were the major changes we made. And like I said, the rest were basically, well, cosmetic, and then for some of them typos, and for some of them were basically some of the spellings. For example, I think you saw the first thing, organization. Basically, we're maintaining British spellings, and so that's about it. I'll be sharing the document on the page so that we can. So yeah, the recommendations are to expand on um the um the objectives. They're a bit short, and so that's what we've done so far, from 3 to 8. Nothing else. The rest, like I said, cosmetic, typos, making sure we maintained British spellings throughout. Yes, we're very serious about it. So if you have any questions, let me know, and I'll be putting it on the page for your perusal. Oh yeah. Okay. All right. I'll put it shortly. Absolutely. I saw another typo. That's why I haven't put it there. So I have to go and fix that one before we put it back. Thank you.
Okay, thank you very much, Dr. Pemka, Secretary. So I think, as you will see, we are really moving ahead in this, reviewing our 5-year strategic plan and the constitution review. Because of the edits that were made, I mean, yet to be done for the constitution review, we will not ask for adoption. But for the strategic plan review, you've had a look at it. We've made the corrections that were suggested. So do we go ahead and adopt that so that we can move on with that? The strategic plan. For the strategic plan. Okay, all right, okay. So now our final thing is the elections. So I'm going to call on Electoral Commissioner Dr. Dede to.
Good afternoon. So we have 5 positions up for elections: president, vice president, organizing secretary, treasurer, and then general secretary. For, as we've said before, is members who are in good standing, those who've paid their dues, who are eligible to vote. So when we are bringing the ballot papers around, please, if you are eligible to vote, just raise up your hand. We have 6 people for the 5 positions, so 4 are unopposed, and it's only the general secretary position that has 2 contestants. Gina, please, can I have the paper, the ballot paper? So for the 4 unopposed, we have yes and no. So if you want to have that person, just take yes. If you don't, just take no. And then for the 2, the 1 position that we have 2 contestants, you take by the name of the person that you want. I hope it's clear. So yes and no for the unopposed, and then take the individual, the one that has 2. So I'll briefly mention, we, like the president said, we asked for nominations. So I think that was about 2 months ago. So we got these 6 nominations, and that's what we are going by today. So I would call out the names and then ask them briefly to introduce themselves to us so that we all know who we are voting for. So for the position of president, the nomination we have is for Dr. Josephine Nsafo.
So yeah, so my name is Dr. Josephine Nsafo. What do I do? So I'm a surgeon at Kolibu Teaching Hospital and a senior lecturer with the University of Ghana Medical School. I'm currently the treasurer. You can always vote no. No.
Okay, then for vice president, we have Dr. Naadoko Aite.
Hello, my name is Naadoko Aite. Yes, just one. I'm I'm a clinical oncologist at the Kolebu Teaching Hospital. Vote for me.
And then for secretary, that's where we have 2 nominations. So the current secretary, Dr. Lily, I don't know how to pronounce your name.
So I'm Lily Pemka. I'm a molecular geneticist. So I work on genetic diseases, and one of them being breast cancer. So what I focus on is characterizing genetic underpinnings of breast cancer in Black women. And also a senior lecturer at the University of Ghana about chemistry, cell, and molecular biology department. And then I'm the and I'm the head of the scientific core at the West African Genetic Medicine Center, WAGMIC, at the University of Ghana. Thank you.
And then the second nominee is Mrs. Jacqueline Odro Akoto.
Okay, so good afternoon. So my name, she has mentioned, Jacqueline Odo Akutu, breast care nurse. I'm currently working at Tema General Hospital, but I've been with Kolibu Oncology Unit for the past 10 years. Thank you.
Thank you. And then for the position of treasurer, Miss Susan Yemedi. Did I pronounce your name well?
My name is okay. Miyam Shishime Kakra. My name is Susan Yemedi. I'm not a doctor. I'm not a nurse. I'm not any of those. So I work with women. I work with youth. I analyze policy. I see where there are issues, and I try to support and contribute my knowledge. And that's what I do. And I'm a survivor. Yes, that's what I'm very proud. Yes, I'm a proud survivor, and I like to move the agenda ahead so that everybody hears about us.
Thank you. And then the last nomination is for organizing secretary, Dr. Ebenezer Oyafe.
Thank you. My name is Ebenezer Yafe. I'm a pharmacist and a lecturer at the University of Science, University of Health and Allied Sciences, Department of Pharmacy Practice. Yeah, yeah. That's where I teach. So I'm a teacher and a pharmacist.
Thank you so much. So at this point, I think I'll call for help. The chairperson of Screening and Outreach Committee, and am I here? If you can just help us to distribute the papers. And then chairperson of Publicity and Advocacy Committee, Riser. So I think amongst the four of us we can. So we'll go around and distribute the ballot papers. So if you are eligible to vote, we trust that you will tell us whether you are or not. We'll give you a paper, just a few seconds. I'm sure we all have pens from our conference bags. So let's take, and then we'll come around and collect it. Thank you. As we come around, if you're eligible to vote, please just lift your hand and then we'll give you the paper.
Hello. Yes, just to reiterate what electoral commissioner said. I think people are still asking. Please, if you were paid BSoG member, so you have to have paid your dues. That is when you can raise your hand and they will give it to you. So if you haven't paid, we are counting on the genuineness of us all. Please don't raise your hand up. Thank you. And then we have, there was one thing I left out, is the financial report. So our treasurer, we can't leave here without hearing that. So Josephine will tell us about that. So I think whilst we do this, maybe if electoral commissioner, are we permitted to do the financial report?
Please, can I have my slides? Okay, sure. Please, can I have my slides?
Please, is there anyone who is an eligible voter who hasn't got a ballot paper? All right, so we'll come around collecting. If you are ready, just lift your hand, we'll pick it up.
Financial statement, please. Can I have slides? I'm hungry. Okay, please, can we present the financial reports quickly? Treasurer is hungry. Please, can I have your attention? Financial reports, please. Please vote quietly. Please vote quietly. So this is the Breast Society of Ghana financial report. Next slide. Next slide, please. Disclosure. So I have no training in accountancy, please. I'm just going to do my best to summarize the audit. So you're not allowed to ask me any difficult questions. Next slide. So the financial year for Breast Society starts from 1st April and ends 31st March. So 1st April 2023 to 31st March 2024. That is what I am summarizing. So we had up to 31st March, we had an income of 11,600 as dues and donations of 180,000, over 180,000. Our total income was 192,086 cedis. And our expenditure was 188,298. So excess income was 3,788. Accumulated fund brought over from the previous financial year was 52,398, resulting in accumulated fund balance carried forward 56,186. Next slide. So for the last financial year, this is a list of donations we received. The last one wasn't included in the audit report. That's why I put it green. So that was a donation from Pfizer Specialties, 3,200, which they paid to Alisa for our 2023 AGM. Next slide. So this is a summary of our general expenditures. So that's a breakdown of how much goes into administration, salaries. The only one on salary is our executive assistant. The salary is so small, so I can't mention it to you. Next slide. You can guess, isn't it? Because it's over 1 year and it's just that amount. So divided by 12 and it's a little embarrassing. We hope to do better. Statement of financial position. So you know we have assets. So this has been converted and we have that as the value of over 21,000 and depreciation, leaving us a net book value of 13,570. Next slide. So dues payments, prepayments is some things we paid for in advance, and then the cash balance at the bank as at 31st March was 8,000 and the cash on hand was 392. If I say the money in the bank was 8,000 cedis and we are still running. So we are really running very close, living from hand to mouth. Next slide. So this summarizes, with our assets and expenditures. So in summary, we would say our net assets is 56,186. So that includes, when we say assets, things like our office furniture and all. So our whole value was just 56,000. If they sell property, sell everybody, we are worth 56,000. Next slide. Now that is the end of the audited report. I don't know if anyone has any questions. After 31st March this year, we have had some donations, mostly towards this AGM. An individual, the video contacted us and donated 1,000 cedis, and we are grateful for that. And these are the list of our donors. Pfizer, the Pfizer grant. When we say grant, is the money is given to us for research, the empowerment study. So the money doesn't come to BSoG conferences and T-shirts and whatnot. So all that is going straight into the research, which we have started. And we have to give a summary and receipts of all that. So unfortunately, we can't chop that money. But they gave us 5% of that money, which will come into BSoG activities. And we have Rush, the media campaign, the radio stations, and the last 2 screenings, Pram Pram and Tuesday Market, all funded by the Rush media campaign. So we are able to pull up these activities due to donations we're getting. We had donation from Gapoha, Pathologists Without Borders, MSD, our major sponsor for this AGM, Rush, as well, also another major sponsor for this AGM. They've even promised to chip in a bit more, so we'll chase them for that. Pharma Symbiosis, Sonotech, I think I received a message they've paid 3,000, Philips Pharmaceuticals, and an individual. So those are the donations we've received so far. Next slide. Membership dues. So we did increase the membership dues for 2024, and we have got 13,500. This is up to maybe last week when I prepared this report. It is a bit more than last year, but then we are paying 200. And last year we were paying 100, so it should be more. Last year we had around 10,000, and now we have about 13,000. So that means we really need to pay our dues. Something missing there. So the membership dues in arrears, when I look at the membership, which was about 250, is about 25,000. We are owing about 25,000. So I'm be standing at the door. Before you go for your lunch, you bring your money. Next slide. Okay, there it is. Approximately 25,000. Next slide. Next slide. Okay, so before I sit down, I'd like to appreciate all your to our sponsors. We've been able to pull off all these activities, including the flyers you have in your bag. We'll be giving them out during October and throughout the year. And membership dues. Last year, we asked that if anybody could pay an extra 100 cedis to support the dues for a survivor, and we have actually received a few. We are grateful. Council Chair supported 10 survivors, a few other individuals too. So we want to encourage you, pay your dues and you pay that for a survivor. But we also do need a bit more. So by December, our rent at Nagrat is up. For monies we had, we were able to pay for the first 2 years. You know, Ghana, when you are paying for rent, it's 2 years. Apparently against the law, but it's 2 years. So we need to pay, negotiate and pay for the next 2 years. They didn't even charge us much. It was just 1,000 cedis because they wanted to support our cause. So be praying with us when we go for negotiation that they shouldn't increase it. Even the 24,000 can be an issue. We have to pay our executive assistant who does a wonderful job. if we don't pay her and she leaves, we can't manage this. So we need, yeah. And then we also, our utilities, we paid Nagrat rent and utilities, and everything is up this December. The activities that have been going on and we've been putting on the platform all takes money. We really appreciate your donations. We appreciate your support. Can I have the Momo number, the bank account details up here? So we are not going to pass off a bowl, but please, I'm still the treasurer, so you can give me your monies before you leave. Any questions? Any questions? Yes, please comment.
Is there a way to incentivize people to pay upfront even? So yes, our dues. So for example, if you pay during this meeting, you can pay the same amount. I mean, there's a probability that we might increase the dues, but that if you pay here, the amount might be the same. You know, something that encourages people to pay.
Any other ideas? But for this year, all paid members did get the t-shirt free. So that was an incentive. You didn't get yours. Oh, they are there. Any other comments? Any other ideas on how we can incentivize people to pay their dues? This year we sent some personal messages as reminders, because I realize some of you, it's not that you don't have the money, it's just that you are too busy. And we should send a reminder at the end of the month. Good idea.
Okay, for an incentive, maybe we could, if you pay 2 or more years, it has a reduced price, especially at the meeting. You understand, like within this meeting, if you are paying for 2 years or more, it should be at a discount. So, no, you get a lot of. It's assured that a lot of.
Okay, thank you. We'll take that under consideration.
But I think those who paid 2 years ago didn't get increase.
Any other comments? Maybe you can tell us what the challenges with dues payment.
I said, as we go into the constitutional review phase now, we should be open-minded about the membership, because a lot of people here, healthcare professionals and survivors, and genuinely will not be able to give us that money that we need to take it to that level. But every Ghanaian with the cancer care at heart, the membership should be reworded and rephrased to make it possible for people to be able to join, irrespective of where they are, and open up to corporate membership. It will be possible for Zenith to say that I'm a member and I'm paying 100,000 Ghana cedis a mentor. So at this point in time, we should think beyond our clinical initial and look at where we are going and open up the membership. So when we go into the comments on the membership and the constitution, let's do it and free ourselves so that we can get more money.
Thank you, Council Chair. So we do have full members, its members and affiliate members. So the corporate organization, by the definition, they are covered under affiliate members. So we do have one or two. We are not taxing them per se, but it's free will. And then on the platform, several times, I did post a message asking that we have written letters. Please volunteer, bring companies' names. You see, there was a time we wrote letters somewhere last year, delivered them. Your guess is as good as mine. It probably stayed at the reception. The problem is if sometimes you don't know someone to do follow-up, and we didn't get anything. This year, Miss Susan took 3 letters, and she followed up personally, and she brought in 10,000 from Gapoha. Last year, Tabitha was very instrumental. She brought in 3 or even more. Yes. So we are counting on you. Ask your family, friends, your in-laws, anybody, and then we'll send a sponsorship letter. And then also there's room for them to register as affiliate members. Thank you.
Okay, so the election commissioner and team, please, have you finished? Okay, if not, we'll quickly do the AOB. So, Lily, I think you have to be there. So, any other business, if there's something that I'm sure by the end of that they will be ready, then we can. Just to mention that we have the October 2024 plans underway. So please get involved. Some of us are a little too passive. We want active communication. It's okay to like things, messages we put on the platform, but we want you to actually be involved. So you are not distant. So when it comes to the launch, and we advertise that, please come and join us here, to be here at the Accra City Hotel. They've been very gracious and they're going to support us through. So please come. Okay.
Thank you. So social media is the new norm now, and I was happy that BSoG Ghana is on YouTube. As a YouTuber myself, it's very important when you encourage people to subscribe. And subscription is also very important to also make YouTube post more of your videos. Okay, so I want to encourage all of us to just take our smartphones, just go on YouTube and type Breast Society of Ghana. You will see it's there. Currently, we have just 40 subscribers. I think if we all subscribe, we are going to move close to 100. Yes, we can do that right now, please. Okay, so if you don't have internet, there's free Wi-Fi. The passcode is here, and let's support the society. Yeah, and let's share the videos that are there to encourage others to subscribe.
Thank you very much, Elsie. Elsie has really reiterated the message. So please, no one here should leave and not be a subscriber of our YouTube channel. You want to add something?
So when you go on the search bar and you type Breast Society of Ghana, something like this will pop up. Then there is a subscribe button in white. Once you type on it, it will turn black and say subscribed. Then there is a bell to the, once you hit the bell, any video that is posted on the channel, you'll get notification. Okay, once you press the bell, just click all, not personalize or none, just also click all, so that anytime there's a new upload, you will get it. Subscribe, thank you. So let me see by hands those who've been able to subscribe and press notification. All right. All right, thank you. Thank you. Thank you, okay. I have to refresh mine to get that. Okay. Thank you so much. Let's hit 100, we can do it. We can do it.
Hello.
Please, you can help somebody. So if you have someone sitting by you who is struggling to find out where A or B is, you can help. We are all here to help.
So when you subscribe, you get a notification, right?
When you subscribe and you press on the bell, there's a bell by it. You press it and you choose all. Just click on the all so that you would get notified anytime the new video is uploaded. Please, let's see those who are having difficulty so that we can help. Okay. The bell is just by the subscribed. So please, some of us, we like putting our data off. Kindly put it on. Otherwise, where is your? And if you don't have YouTube also, then you have to also go to Play Store or your iOS and download it. Yes. Please, I'm coming.
78.
No, this is, you are on the Google. So it means you've not downloaded it.
80. So the numbers have doubled. Yeah, from 40 to 80. 82.
So whilst we are still at that, anyone else wants to say anything? If not, then I think we will. Okay. 85. Can you give the phone to her?
Thank you. So I like the idea where you said we will have to pay for the AGM. I think that will be good. Then you give discount to early bird, those who will pay earlier, and then the discount will be a motivation for members to pay their dues, and I think that will generate income for the society. Thanks.
Thank you very much, madam. Please, your name?
Grace Radio Ajiman.
Grace Ajiman. Thank you very much for that. Any last comments?
Okay, please, I also want to say that I also have a YouTube channel. So it's Medcare Hub. You see, we are trying to let the whole world know that it's normal to also survive breast cancer. When people can relate with somebody who have survived, they are confident to go through the process. So what I do on my social media handles, I tell stories of survivors. I tell what to look out for and how confident I have become after surviving it. So the support from members of BSoG can also help my video go viral and get people and get the conversation going on. Okay, so please look for me on Medcare Hub. That's the name of my channel. MEDCARE. It's one word. Then Hub, HUB. Search for me on YouTube, Facebook, Instagram, TikTok, and let's get the conversation going. I get a few survivors who come on my program to support and to comment on it, and that's very good. So please, after you subscribe to BSoG's channel, kindly subscribe to my channel as well.
Exactly what I was going
Thank
to
you.
say, Elsie. So push BSoG channel as well at your channel. All right, thank you very much. 93 now. Wow, thank you very much. So our electoral commissioner is seeing. When she's done, we will move for closure of the meeting and then closing prayer.
Okay, so we had 65 people who voted. I will lump the noes, the abstains, and the spoiled ballots together. So some people voted no, some people abstained from voting at certain places, and then some of the ballots were spoiled. So, as in, So for the secretary, for instance, 2 people ticked both of them. So that's a sports ballot. All right. So I'll lump all of that together. So for the president, Dr. Safo, she had 64 votes, and then 1 on the other side. And then for vice president, Dr. Na Adoko Aite, she had 63 votes, and then 2 on the other side. The treasurer, Ms. Suzanne Yemedi, had 65 votes. Everybody voted for Suzanne. And then organizing secretary, 63, Dr. Ebenezer Riafe had 63 and 2 on the other side. The secretary, so Dr. Lily Pamka, I shouldn't mention the E, that's what it's called. Pamka, good. Had 29 votes. And then Mrs. Jacqueline Odro Akoto had 34 votes. And 2 votes were spoiled. So those are the those are the results. Congratulations to the incoming executive. So the current executive would work with the incoming one for the next 2 months, September, October, and then by beginning of November, they will hand over fully. Thank you.
Thank you very much, able electoral commissioner and former president. Thank you very much.
Okay, thank you. Please, I wanted to suggest about this rental issue about Nat thing, Nagrat thing. If Nagrat and Nat is paying a little amount to Sweden Ghana Limited concerning survivors of treatment over there, I want to suggest if we can put in appeal to them that they are rent place, if they can do something for us, because teachers are also there and you are paying something to Sweden Ghana Limited. If they can also pay that rental for us from the teachers' coffers, because a lot of teachers are also what survivors and breast cancer. Now, say yes. Now I want to put into the NAT people if they can do that. Not the NAGRAT, it's the NAT aspect I was talking about.
Harriet Echuadaku. Okay, thank you very much, Sir Harriet. So, like Council Chair was just saying, our offices with NAGRAT, the graduate teachers, not with NAT. But I think, like you said, we can still find a way of appealing to NAT. So it's still a very good suggestion we'll take forward. Thank you very much. So I think before we go, we like our electoral commissioner has said, so we'll start working with the new executives, and then from the 1st of November, they will take over fully in office. So whilst we are here, I would like to call them just for us, and then we congratulate them. Dr. Josephine Insafo, President. Dr. Naadoko Aite, Vice President. Josephine, please move down. Miss in Mrs. Jacqueline. Jacqueline, please. Sorry, I just Mrs. Jacqueline Odrakoto. Yes, Secretary. Organizing Secretary, Dr. Ebenezer Riafe. Treasurer, Miss Susan Yemedi. So congratulations. Congratulations, executive. So executive audience, your executive, new executive members. Okay. Thank you very much. Please, you can have a seat. So can we ask for someone to move for closure of the AGM, and then 1 to 2nd, please? Yes, okay. So Dr. Amadia Tete moves for closure of the meeting. Any seconder, please? Please, can you mention your name? Okay, Mrs. Elizabeth Sam, seconds for closure. Riza Sambu, can you come and give us a closing prayer, please? After that, Charles, any announcements for lunch? Okay, so they are the coupons which will be given. Oh, lunch will be warm, don't worry. They are the coupons.
And then we appeal to all that please leave your name tags at the table for us. Thank you.
Yes, please. This time we've decided you could take the name tags. Some of you want to keep them. And we also have the small small flags here. Unfortunately, the QR code, I don't think it really works, but you can come and pick one. Maybe you put it on your on your office desk. Okay, thank you. Okay, another announcement. After the closing prayer, we are supposed to be leaving the room. I think they are preparing for another. So please take out everything you brought. We don't want to carry any extra bag which has been left here. Please, thank you. Rise.
Shall we bow our heads for a very short prayer? Heavenly Father, we thank you for making this annual general meeting successful. We ask that you continue to grant us the resources to carry out our mandate. I commit every person here into your hands, O Lord. I ask that you take us back home peacefully and safely. In Jesus' name, amen.
Thank you all for coming. Enjoy your lunch. God bless you.